Good spot, yeah.
All right, start here with the numbers.
I did do it.
Look ahead.
Okay. We'll start the meeting. Thank you. Welcome, everyone. I'm Commissioner Rod Beck. I'm the chairman of the Ada County Commission, and therefore I'm chairman of this meeting today. I'll call the meeting open. This is the Public Health District number 4 Budget Committee meeting in order today. It's Friday, May the 9th. The time is 10 o'clock to consider a proposal for fiscal year 2026 budget for Central District Health. Budget Committee consists of the chair or designee from each of the 4 counties. If you could identify yourself for the record, we'll start over here.
Commissioner Caldwell, Valley County.
Okay. And you're the designee from the chair of the county. Yeah. Okay.
Sir.
Commissioner Clay, Chairman Clay Tucker from Boise County.
Chairman Crystal Rogers from Elmore County.
Okay. Well, it seems like we have everyone here today. The first item on the business is to approve the minutes from the last budget committee, which was a year ago today. Oh, wait a minute. I guess, are there any changes to the agenda that you'd like? If there's no changes to the agenda, I'll entertain a motion to accept the agenda as it is.
I'll make a motion to accept the agenda as written.
Second.
Okay. It's been moved and seconded. All in favor, say aye.
Aye.
Motion carries. We now have our agenda. This is the agenda. First item on the agenda is to approve the minutes of the last meeting. The viewing the Public Health District 4 Budget Committee meeting from May 10th, 2024. I will accept a motion to approve the minutes. Okay. Do I have a second to the motion?
I will second that.
All right, we have a second to the motion to approve the minutes for the May 10th, 2024 meeting of the Budget Committee. All in favor, say aye. Aye. Motion carries. All right, next we have up on the agenda to discuss and vote on the proposed FY26 budget. Or any questions or issues on the FY26 budget. In your packet, it has how much of each county will pay in property taxes in this budget. Any questions about the budget? Questions or comments? Okay. I will comment. We have asked, we have a slightly larger portion of the budget than you counties. And we have asked Russ to go through his budget and identify any state mandates that are there that are required by the state to do. And then we want to apply that to how much the requirement is to our property taxes. Because people in state government have been saying, well, we don't collect any property taxes. We don't spend any property taxes. Well, they do. Because we spend what's our portion of the budget? It's about
90% of the county portion.
about 90% of the county portion, but everybody spends a year, and that's a formula written in the code is how that's determined, and it's based on population and assessed valuation, I believe. But yep, that's how it's determined. It's what's your population and your assessed value. Well, a portion of that is because the state requires us to do it. And I'll give you one good example. The food inspection for the restaurants, that's a requirement that be done. But then the fee that's charged is set by law. And it doesn't pay for everything. How much of can you give us an idea how much of the food fee actually goes to cover the cost of doing the inspections?
Mr. Chair, it's about $800,000 in District 4.
That's how much it costs?
No, the program is closer to $2 million, so it's close to 50% of the cost for us to do the program comes out of property taxes, and the rest is paid for by fees.
That's my point. There's a portion of it that is paid by property taxes. And the legislature will not allow the Central District Health to raise those fees. And we're gonna be proposing at the Idaho Association of Counties, that there be a bill to allow each county to set those fees to more offset the cost, because that's a direct property tax fee that we're paying to do a requirement of the state. So that's one thing we're doing, and I'd suggest you all might want to join in. We have also asked each one of our directors and our elected officials to do the same thing. When we consider our budget, how much of your budget is a requirement of state law? And then we'll have some exact, some pretty precise numbers that we can relate. Now, cities are a little different. Cities are not, they don't have as many mandates as counties do. But counties have, I mean, we're all required to have jail. We all required to have a landfill. We do all those things, and they're all requirements of law. So we're gonna have some pretty good numbers, and I appreciate for us being able to do that. All right, is there any questions or any discussions on the budget? You have a copy of the budget with you. Or any discussion or comments on the budget? Okay, well, I will then call for a motion to adopt the budget.
I will make motion to adopt the FY 26 budget as written.
Okay, going to have a second for the motion. All right, is there any further discussion? Okay, all in favor of the budget as written, say aye. Aye. Carries. Okay, now we have, well, the motion has been approved and accepted for the proposed FY 26 Central Committee or Central District Health Budget, District 4. And this concludes meeting of the Budget Committee. So we'll be adjourned. Thank you.
Thank you.
Thank you.
If you'll sign that, I'll take care of the rest.
All right.
It is 10:17 and we'll call this May 9th Central District Health Board meeting to order. First item is I've asked Corey to do a silent roll call, and it looks like we've got a quorum. The next item on the agenda is to approve the agenda. Now, this time we can't do it by unanimous consent because we had to make a modification to add the board elections. And so if we could have a motion to approve the agenda as amended, including the board elections, I would appreciate it.
A motion to approve the agenda as amended.
Second.
All right, all in favor?
Aye.
Aye. Opposed? All right, the agenda as amended and presented in the packet is approved. The next is we'll approve the minutes from last meeting by acclamation unless there's any objection. Seeing none, the minutes from last meeting are approved. And signed. All right,
Mr.
and
Chair, Betty has a question.
Mr. Chair, in appreciation for their participation and recognition, could we have our guests announce, introduce themselves, please?
all of the guests,
Staff here, which
Right.
we know, but yes, the guests.
okay.
And they don't know us,
Oh, I see.
yes.
All right. So. Start.
Welcome, everybody. I'm Dr. Ryan Cole, a member of the CDH board.
Commissioner Clay Tucker from Boise County.
Commissioner Crystal Rogers, Elmer County.
Jane Young from Ada County.
Russ Duke, Director.
Greg Furch from Ada County.
Oh, Corey Kennedy, I'm the recorder for this meeting.
I'm Betty Ann Nettleton from Elmore County.
Commissioner Catlin Caldwell, Valley County.
All right.
Wanna go?
All right, welcome, everybody. Next on the agenda is public comment. I had that moved towards the front of our agenda this month, so everyone would have an opportunity to weigh in on some of the subjects we're going to be discussing today. So first up is, and forgive me if I
Sydney Buffington. Sorry.
mess up a name, but Sydney Buffington. You'll have 2 minutes. We'll head over by the podium for us.
What happens at 2 minutes? So you can.
Good here, good this meeting.
Yeah, there's
We have the shepherd's hooks.
Okay, okay.
When you're ready.
I'm good. Good morning, Chair, members of the board, CDH staff. My name is Sydney Buffington, and I am, among other things, a retired nurse who left the emergency room for the field of public health in 2010 and chose to dedicate my service to public health in the field of communicable diseases. Today, you are here to vote on the question of whether or not CDH should continue to offer the COVID vaccine. My response is a resounding yes. I hope that you will vote to not change our current practice. I have 2 basic points to share. There's lots of things I could have said, but I narrowed it down to these 2. Point 1 is that I feel that public health, in order to be able to promote and protect the health of the communities, that is in our mission statement, requires a foundation of relationships and trust in the community. People must trust that the messaging, education, and guidance offered by public health are based on the highest standards of practice in the field. An essential subgroup of that community is the medical community, who look to public health for information and guidance that goes beyond what they're seeing in their individual practices. These providers must know that their local health department is making decisions based on the best science available. The medical community does not doubt the safety and importance of the COVID vaccine. I fear that if CDH votes to not offer this, that these relationships of trust that have been built up carefully over the years will begin to erode. Point two, at some point in the pandemic, after vaccines did become widely available and deaths began to decline, we decided to shift the burden for prevention of COVID from the general population to individuals at risk of complications or death. Anyway, please do not deny this vaccine that's the first line of defense for the elderly, immunocompromised, and the people that care and love for them. And please do not erode the trust in public health. Thank you.
Very good. Thank you. Doug Cameron is, I'm gonna go first, up next.
Hello, my name is Doug Cameron from Elmore County. I am willing to show you all my medical records with images and financial costs, which exceed $2 million as of today. I received on April 5th, 2021, I was injected with a gene therapy COVID-19 vaccine at my workplace. On the 15th of April, I was permanently paralyzed, as you see me here today. My doctor said they have never seen anything like this before, and have heard of nobody having anything like this being reported. Rare was the word they used. The proper word for what happened to me is called hemorrhagic transverse myelitis and blood clot in my leg and spine, which hemorrhaged. I spent 105 days in 3 different medical facilities: St. Luke's, Boise; St. Alphonsus Rehab, Boise; Craig Nielsen Rehab, Salt Lake City, Utah. Before you say, how do you know the vaccine did this to me? While I was in ICU and could not raise my hands or speak or anything, my doctors reported my injuries to VAERS, Vaccine Adverse Reaction Reporting System. The doctor reported it, not me. I didn't even know what VAERS was. Since coming out of the hospital at the end of July 2021, I tried to learn as much as I could of what happened to me, and some of the things I found out, I could not believe what was happening or could happen in this country. One of the most disturbing things that I have found out was it generally takes 5 to 15 years to develop and test a vaccine. And it comes in 4 stages, with the 4th stage being the most troubling for me. I believe we are in the 4th stage of these genetically modified COVID vaccines, and the side effects are showing. We are starting the 5th year of a 15-year world trial. I hope we vote today on quit the funding of the mRNA COVID genetically modified vaccines. And there is no doctor here today, who can tell me what the side effects are going to be for our future generations. But we will all soon find out. Thank you for your time.
Thank you, Doug.
Thank you.
Laura Demare is third on the list, and then Corey, are you grabbing? Okay.
Thank you, Honorable Board, for having me today. I'm Laura Demery. I share my own opinions. Today, we contend for life, health, our children, and our cellular integrity. VAERS data shows over 19,000 Americans are dead from the shot, 19,000 permanently disabled. Idaho has 35 deaths and 108 permanently disabled. The gene therapy vaccines did not prevent COVID, its transmission, its hospitalization or death, but it's distributed throughout the body, including brain, eyes, heart, ovaries, testes, bone marrow, fetus, and Yale found it persistent after 2 years, still causing chronic disease. Rancourt et al. Demonstrated 17 million deaths worldwide, and the recent Greek study demonstrated 45% of the proposed COVID deaths were not related to COVID at all. Pfizer docs and 3,800 peer-reviewed published studies prove this harmful product leaves over 1,200 sequelae in its wake with no mercy for its victims. The injured and the docs who spoke out to show the real science were persecuted, fired from work. Docs lost businesses, grants, slandered, censored. They were slandered, censored. Discussing science became a revolutionary act. My injured were abandoned, treated like lepers. They were told to die by the public, ignored by sometimes over 40 doctors, including in Idaho, and told it's all in their head that they can't walk or going blind, have cardiac, neurological, autoimmune issues, or an average of 20 new debilitating symptoms since the jab, and it cost them $50,000 to $2 million within 3 years. React 19 has 40,000 members of the forgotten injured like Doug and Lori. The emails are still pouring in. I'm a small volunteer at that group. The COVID shot is not about freedom because it's not a free market choice. When billions of taxpayer dollars were put into the coercion to take it, it became a non-market advantage. And I just ask that Idaho is a state that values life. I implore you as my lesser magistrates to hold the line and vote to defund this harmful product and stand in the gap for all of us. Thank you for your time and your service. Thank you so much. If you have questions. If you have any questions, have you heard?
Next is Lori Peters.
Dear Honorable CDH board members, I am Lori Lee Peterson, and I support defunding the COVID injection due to severe cases of harm it has caused. I have lost everything I've worked for my entire life. I used to think my home was my most valuable asset. I was wrong. It was my health. I bought my first home at age 23 and promoted to quality supervisor at age 25. I believed in safety and quality over profit. Lives and reputations were on the line. Our children's safety and their quality of life is on the line if we continue to use gene therapy vaccines. My American dream was stolen the day I believed in the science, and I got the COVID mRNA Pfizer vaccine. Since I've been diagnosed with myocarditis, which I continue to struggle with, and autoimmune disease RA, I'm currently being reevaluated for lupus due to skin inflammation along with muscle pain and extreme fatigue. In addition, I have spike protein levels beyond measurable and no answers if these levels will ever wane. And not just my life has been affected, my dogs no longer have a mom they deserve. My father has a daughter he does not deserve. He spent half his retirement savings paying for my mortgage until we both realized I was not going to get better. I had to sell my home that I only owed $42,000 on. I lived off the proceeds until my disability was approved. My mom and stepdad helped care for me. I now live in their backyard in an RV. My entire family has lost me. I am no longer the person I was. They've watched me achieve greatness and my American dream to now merely existing. I have battled with thoughts of suicide, depression, and feeling that I will no longer again be able to achieve the American dream. My hopes, my ability to work, and my future is unknown. I was denied the CICP claim because I did not file within a year. I have no savings left. I live on a fixed income instead of working. I loved working. Working was my identity. We cannot continue to risk our children's lives. I ask you, please, do not allow what happened to me to happen to another person in Idaho. Please vote to defund this harmful product today. I'm not alone. Many people, along with children, have gone through similar life-altering adverse effects from this debilitating product. Idaho strong. Thank you for your time. Feel free to ask me any questions.
Thank you, Lori. Okay. Suzanne Young,
Haley.
Yaley,
It's scary.
knew I'd messed something up.
Mr. Chair and members of the board, I am Suzanne Yaley from Ada County. Please do not limit the choices of vaccines available from the Central Health District by removing COVID vaccines from those available. Many young families use district health services for access to affordable vaccinations. I was very thankful for those services as a young mother, and my daughter uses district health services for her two young boys. Please leave the vaccination choices up to each family. Thank you.
Dr. Blue is next on the list, but you are still here to answer questions? Okay. Then Heather Wenger. Heather?
I think the children, they're probably walking over because they're watching.
They're over, sorry.
Um, yeah. Okay, it's gone. Heather?
Morning. So so what does it mean, please?
It'll be when it's 2 minutes in a row.
Okay, and so it'll just be yellow until.
Yep.
All right. So are you restarting it? I'm probably gonna get 2 minutes, thanks. All right, good morning, everybody. I am grateful to CDH for having this discussion and discourse today because the drug inserts for these injections is still blank. This is truly unacceptable and it makes us not a real pharmaceutical product in the way that most people think. People don't understand the fundamental difference and what it means about the real safety and efficacy trials. They trust their doctors and will get this medical intervention because their doctors encourage them to. And their doctors themselves don't have enough time to research what and how research has been truly completed and or incentivized by the insurance system to have a certain percentage of patients vaccinated, which is a misnomer because this is a gene therapy injection and not a vaccination. In fact, when my own son was injured, his doctor did not know about the side effects that were there. And so when the health department offers, encourages, and even pays for these shots, people automatically assume that the health intervention will be safe and effective and only in their best interest to get it since it's offered. My own vaccine injury story was being censored online in 2019 before this. So, and it had been censored so much that I didn't fully understand. So, about the COVID shots, my husband's close family member, a doctor, early 50s, ultra athlete, 2 teenagers, after his 3rd injection mandated by his hospital, died. Heart attack, his family knows, it's in theirs. My friend's husband, late 40s, started having massive stomach issues, lost 30 pounds, 3 months, finally figured out it was ulcerative colitis. Doctors determined, yes, it was from the shot. I have a friend who's currently at home recovering from massive fibroid tumors that started as soon as she had gotten her, she's gotten at least 6 of them. So they're not safe and effective. We need more discourse. We need more, and I appreciate everybody listening. Thank you.
Last on our list is Stephanie Nemore. Right there.
Good morning. Commissioner, thanks for the opportunity to provide testimony today. I'm a mom, an Idaho resident since 1986, and I have 2 kids that are about to enter kindergarten. I'm here to ask you to keep the COVID-19 vaccine open and available as an option for parents to choose for their own child or children. People like me, I'm not a healthcare professional, look to the Central District Health for expertise and recommendations on how to best care for their family. And I think that is done especially when if you don't have a family care provider, or when someone you can regularly go to, the Central District Health is a place you can go for reliable information. So we need to keep the COVID vaccine on the list of recommended vaccines, which helps the goal of preventing vaccine preventable diseases. This information arms parents with the information necessary to make a choice about their own child's health care. We as a community need to have Central District Health continue to offer the COVID-19 vaccine to families. It's pivotal to the health and of our community. Thank you very much.
Thank you. There wasn't nearly as many testifiers as we left time for. And so we are a bit ahead of schedule. So
Katie's here, she's ready.
okay, so I'm going to make a final call for public comment. Anybody in the room that wants to have their 2 minutes on this subject? All right, if not, next on the agenda is our Meridian Anti-Drug Coalition Volunteer of the Year. And I'm going to turn over to Russ.
Okay. So I wanted to, introduce Katie. She's part of our health promotion and health policy team, and she is it's appropriate in public health to say a rabid educator on the harmful effects of vaping and smoking. And she's been doing an amazing job throughout our public health district. And very recently, she received the Meridian Anti-Drug Coalition Volunteer of the Year. And I just wanted to read what they had to say about her. And then I'm going to ask her to share with you a little bit about the work that she does. So Katie's hard work and dedication to prevention has been noticed by many throughout the community and the coalition. So much that she was nominated and awarded the Meridian Anti-Drug Coalition Volunteer of the Year at the April meeting. And this is what they had to say. She has served on the executive committee as the government sector representative since 2023. Katie has been very active in getting the Anti-Drug Coalition and CDH prevention information out to the public, specifically vaping and smoking prevention, and how the brain is affected by these substances. She also helped bring West Ada School District, the Anti-Drug Coalition, and CDH together to educate parents at athletic and other school venues and events. She consistently shares useful information at our meetings, contributing insights that help drive our initiatives forward. Beyond her knowledge, Katie is always ready to lend a helping hand whenever it's needed, embodying the true spirit of service. Her passion for prevention and the well-being of our youth shines through in everything she does. Katie's commitment to creating a healthier, safer community is both inspiring and effective. Perhaps most notably, she brings a contagious energy, which you'll see here in a second, to our monthly meetings, keeping that team motivated, engaged, and focused on our shared goals. She's an outstanding volunteer whose dedication and passion make a lasting impact. Katie's contributions are deeply appreciated. Thank you and congratulations. So, the floor is yours.
Well, first of all, thank you, Russ, for inviting me to this meeting. This is my first ever Board of Health meeting, so I'm happy to be here. Of course, I'm nervous, but you guys seem pretty cool. So, As you mentioned, I'm a health policy analyst. I oversee the tobacco control and youth vaping prevention programs. I am on the Division of Community Environmental Health side of CDH for the health policy and promotion team. I have my program manager behind me supporting, named Sierra. And I'll give you kind of a high level of like what I do day to day, but a big component of my job is outreach and education. And that's probably why I was awarded this, because we are going out in the community and doing so much work with youth vaping prevention. Of course, I'm partnering with schools in every capacity I possibly can. And so, for an example, we are working really hard to get evidence-based prevention curriculum into schools, most notably one that's called Catch My Breath, which is an evidence-based youth vaping nicotine prevention program that helps build skills in 5th through 12th graders to resist peer pressure and to be able to identify marketing tactics by the big tobacco industry that have always been deceptive and trying to get them hooked on their products. So I will say that in the last school year, we've had about 8,200 youth in that program, and we've been able to expand it by having 41 community members trained. So we're gaining traction. I'm just hoping that the popularity of this program and our outreach efforts go into the next years to come. Another thing that we do with schools is we bring an inflatable brain, as you probably heard in that awesome summary that Russ mentioned, is we have this crazy inflatable brain that we have that you can walk through that has really cool information on it that is tailored to youth, professionals, adults, you name it. And we bring that to schools and we have them talk about what is mental health to them, what is brain health, and how does vaping impact those things, and what can they do to keep it healthy. And we actually get data from the youth. They write it on sticky notes, they get free items. That's how we were able to coax them. And that data goes into an Excel spreadsheet and it doesn't stop there. We actually provide impact reports to the schools. That way they know what their students are talking about, what they already know. And we use that to our advantage so that schools are being able to have suggested strategies to have more prevention and primarily getting that curriculum in there. So that brain goes to community events as well, or it doesn't. Sometimes we just have a table with resources there, which is still impactful. And we've been able to reach about 7,600 community members in the last year by just going to community events. So that's been successful. And then some parents, guardians, family members, general community members aren't really able to go out and about to events. And so we try to hold virtual education sessions that we do quarterly. And that was started this last year by me. And the first meeting was only 0 people at. So that was, I was sitting there for 20 minutes on the call, like, is anybody going to show up? And I just continued that effort. And second meeting, I had 15, third meeting, I had 27. And then just on April 28th, I had 56. So it's getting popular. And the only reason that is one, I'm passionate about it, but two, it's because of our community partnerships. We really value our community partners and they help promote these things. So on top of outreach, we do monthly newsletters. I've had about 800 monthly newsletter opens in the last year. And so I thought that was a good statistic. We talk about facts, ways to get involved. We talk about quitting resources, different coping skills that people can try. And then another big component of my job is policy and making sure that I'm promoting tobacco and vape-free communities, whether that's in schools, parks, businesses. So we make custom signs for people. We have 5 school districts that have adopted outdoor custom signs that we've created, and we also put them inside of their school. And we also really landed a good partnership with Cascade School District this year. It's a rural community, K through 12, all in one building. And when I first looked at their policy, it was this big. And I thought, I really want to help these people. I know that they, you know, the PE teacher is also the health teacher. He's also the coach. He's also the counselor. So like, I get that it's really hard for some of our schools to really be able to adopt some things pertaining to tobacco and vaping. And so convened partners that were all passionate about this up in Valley County. And we were able to help them revamp their school policy. And it wasn't just with tobacco, it was with other substances. And so they now have prevention, intervention, and cessation with a tiered approach for their policy in their school. One other big highlight that I will say is that we've landed a really good partnership with West Ada School District Career Tech program. They have a program where if a student wants to go be a veterinarian, then they can do this career tech program and get veterinary skills or nursing skills or what have you. Well, we've partnered with their digital marketing program. And so we go in, we teach these students about tobacco and vaping and the impact of it and what coping skills are. And then we act as their client and they create marketing materials for us that they can put in their school and that we can take and put in the community. And so we value the youth voice and we really want to make sure that they're the ones that are changing the norm, because I can go into the classroom, Russ could come with me and go in the classroom. Honestly, anybody here could probably go in, but it won't resonate with them as much as it would if their peer was telling them it's not good for them. So that's been an excellent partnership, and we have a commercial that's being made right now and I can't wait to get access to. So all in all, I've been working here for coming up on 3 years in December, which feels long and short. And it's only taken me a little bit of time after I first started here to realize that community partnership and collaboration is really what public health is all about. I came from veterinary medicine before this, and it's a lot different. And I know that while I'm honored to receive this award, I know that I really received it because of the excellent and exceedingly passionate people I work with, not only at CDH, but in our communities that we serve. So that's all I have. I have a lot that I do, but I don't want to bore you with too much. So thank you for having me. And if you have any questions, I'd love to answer them.
Well, we've got a couple of minutes, so I would like you to share your kind of educational background. You mentioned history and veterinary, maybe expand on that a little bit.
Mr. Chair, you do this right? I initially went to school to be a veterinarian. I have my bachelor's degree from Washington State University in Animal Sciences, and I did pre-veterinary emphasis. So I was in all the classes as the nurses and doctors and stuff. I got into vet school, and that was right at the brink of COVID-19. And I call it a come to Jesus. I thought, this is not for me. I've been doing tech work. I do not want to be with compassion fatigue. And I changed course, and I knew that I was really passionate about zoonotic disease. So diseases that pass on from animals to humans. In fact, I actually served on the rabies response team for a little bit. And I did my MPH online through the University of Missouri. So I got my master's in public health in July 2020. And I was looking for a job just to get my foot in the door. And this one, it just landed in my lap. And, you know, it's interesting because I'm not even curious about zoonotic disease anymore. I've gained such awesome partnerships in the community when it comes to substance use prevention and intervention and cessation, that this is something I'm really excited about doing. And I do think there's a fire in my soul because I grew up around substances and I'm very passionate about preventing them and helping people build healthy coping skills. So yeah.
Very good. Thank you. Anybody? Dr. Hill?
Thank you for serving the youth of our community. And thank you for your energy and positivity. So it will resonate for generations. So thank you for what you do.
Mr. Chair, can we get you up to Garden Valley with that big brain?
Mr. Chair, absolutely. In fact, you know, the first year that I was here, we went to Basin School District and we brought the brain and talked to the 7th graders and they loved it. But we have not been invited back yet. And I'm hoping that that will change. I know there's been some modifications in that community going on with schools and everything. So, yeah, if you have any connections,
I know.
let's do it.
Good. Anybody else? Well, thank you. Congratulations. Take a break. Something popped into my head as you were talking about marketing tactics of tobacco companies. There was a marketing campaign with the American Medical Association and promoting tobacco. And thankfully, when we find that things are ineffective or in fact harmful, we're willing to change our policies and move on in the interest of public health. So thank you for being at the tip of the spear on that. I think we will take about a 9-minute recess. And we'll get queued up for the presentations.
Okay. And then,
For recess.
and it would be back around like, in like 7 minutes. There's like a process because of the room's technical difficulties, how we're gonna have to do this as far as the speaker speaking, and if you guys have questions, but I'll explain that when we get close. So you guys have time. Yeah, thank you.
We're going to call our Central District Health Board meeting back to order. Next on the agenda are some presentations by some volunteers on the COVID-19 shot subject matter. And first up on our list is Dr. Munch from the Central District Health. And so
Mr. Chair, honored members of the board, I appreciate it. I'm Dr. Mudge, and I also have Savannah, who's one of our clinical staff here at Central District Health, who will be doing this presentation with me. You'll hear me. I know I'm a little bit not a loudspeaker, so let me know if I need to speak up. So I was asked to just give some background on COVID-19 mRNA vaccine, and I'm talking broad strokes. I did want to acknowledge how that many people came out. This is really important subject matter for people, and I appreciate everybody airing their views and having this discussion today. Our objectives are to talk briefly about mRNA COVID vaccines, discuss the efficacy of the vaccines, and then review COVID-19 vaccination at Central District. So what are COVID-19 mRNA vaccines and how do they work? So they've been around for decades, mRNA technology, but during the COVID pandemic, they came to the forefront with Pfizer and Moderna. Next slide, please, the first controlling slide. And they use a piece of the something small called mRNA to deliver instructions for a spike protein COVID, the COVID virus. The mRNA is enclosed in a lipid nanoparticle and is delivered into muscle cells with the injection of the vaccine. The cells then use the mRNA as instruction, and it produces a spike protein to display on their surface. And then the immune system then responds by making antibodies and memory cells to defend against the actual virus. mRNA is quickly broken down by natural processes within a few days and does not enter the cell's nucleus. There's not the tools available in the cell to do that. Next slide, please. So safety and efficacy, this is something, of course, everybody's very concerned about. The initial clinical tests were 70,000 participants. And then since they initially rolled out, we've had billions of people worldwide who have been given mRNA vaccines, and they've seen similar side effect profiles in all countries as what we saw in our US clinical study. The main side effects are what we categorize as mild, although of course I appreciate that might not feel mild when you get that really sore arm, but fever, fatigue, sore arm. There are a few rare, very rare, rare side effects that I did want to bring up. Anaphylaxis, which is at the same level or lower than all other approved vaccines in the United States, and then also myocarditis and pericarditis, which I'll talk about in the next slide. Many studies have been performed now that show no increased risk of miscarriage, birth defects, or fertility issues. And there's ongoing safety tracking in all the normal public health organizations, both nationally and worldwide, in all the countries who also have approved the mRNA vaccines through their own methods, and then also international independent agencies like the Global Advisory Committee on Vaccine Safety. So myocarditis and pericarditis. After mRNA vaccine, we're talking about inflammation of the heart muscle and inflammation of the lining of the heart. This was a signal in the initial clinical trials and has continued to be seen at very rare levels in the larger post-authorization surveillance. They more often are seen in younger males, like teens to 20s, and after the second booster dose. And we have noticed that with just the second dose, now with the just once a year booster, we've noticed that that's really decreased. Symptoms included chest pain, shortness of breath, rapid heart rate, and fatigue, and they usually appear within about a week of the vaccine. And most individuals with vaccine mediated myocarditis or pericarditis have what we categorize as mild symptoms, and they often respond well to anti-inflammatories, rest, plus or minus some of the other therapies we use, steroids, etc. And symptomatic relief for the vast majority of individuals was documented to be within 6 months. I'd like to bring this up in the context that the actual COVID infection and natural infection from COVID is very pro-inflammatory. And so people who are infected with COVID, the actual infection, have a much higher risk, 15 to 20 times higher risk of developing myocarditis or pericarditis or other heart problems. And if you have a natural infection that leads to those outcomes, it tends to be much more severe. International studies have confirmed all these similar safety profiles, and agencies like the American Heart Association still strongly recommend the mRNA vaccines because the risk of the vaccine is so much less than the risk of the natural infection. Next slide, please. In a discussion about vaccines, I think it's important to bring up long COVID, which is symptoms after a COVID infection that can last weeks to months. The symptoms might be fatigue, brain fog, shortness of breath, and joint pain, sleep issues. These cause pretty significant economic issues, social issues, mental health issues. And many studies have now shown that COVID-19 vaccination can reduce these risks by 30 to 50%. And in fact, some people who have long COVID have benefited from receiving the vaccine to reduce their symptoms or prevent it from worsening. And we think that's because the vaccination helps prevent those severe infections and so decreases that inflammation and also minimizes the persistence of the virus in the body. Next slide. Many of us have been very aware in the news that COVID-19 continues to evolve and there's new variants, new subvariants, and also that our natural immunity from a COVID infection or from the immunity from the COVID vaccine does decrease over time. And also with the mutation of the variants. And so boosters have been developed to address those new variants, restore protection. And these have been found to be very effective. They prevent severe illness, hospitalization, and death 50%, even with the new variants because of that cross reaction. There's enough similarities that they're able to still provide protection. Boosters are especially important for high-risk groups, the elderly, immunocompromised, and chronically medically ill. And the technology allows for rapid adaptation of the boosters to match new strains. So for some months instead of a much longer period, for example, for flu vaccines, the flu vaccine. Next slide, please. So why do people choose to get the COVID-19 vaccines? Especially as we have noticed, COVID-19 infections have grown more mild over the years, thankfully. At least for now, with the current strains. But nonetheless, people might note that there's still millions of illnesses. There's hundreds of thousands of hospitalizations and tens of thousands of deaths annually in the US. And this year alone, since 2025, COVID-19 has caused nearly 11,000 deaths as either the cause or main contributor of death in the United States. Vaccines are known to continue to be highly effective against preventing severe illness and death. And it reduces the risk of long COVID. It prevents virus transmission to our loved ones, our colleagues. People may choose it for children because it reduces the risk of severe illness, long COVID, and also really serious illness called multi-system inflammatory syndrome of children. And then also pregnant women may choose to receive it because it reduces their risk of severe illness. You're in an immunocompromised state when you're pregnant, and you're more likely to end up in ICU and on a ventilator with a COVID infection. Prevents preterm birth from illness, of COVID illness, and also antibodies can pass to the newborns and protect that baby after birth. Both the ACOG and AAP, the big major societies for pediatrics and obstetrics, strongly recommend vaccination for these groups. And then also some people might choose the vaccine because it helps minimize the prevalence of the virus in our community, and that helps protect the people who might not be able to protect themselves, vulnerable individuals, the elderly, and the immunocompromised. But that'll hand it over to Savannah to talk a little bit about vaccinations at CDH.
Thank you, Mr. Chair. I'm Savannah. I'm a nurse practitioner here at CDH. I've been here almost 6 years.
So here at CDH, we currently do offer COVID-19 vaccination as well as all other vaccines that are recommended by ACIP and with the national immunization schedules. They are available for children and adults with and without insurance. We offer vaccines at no cost to those who are uninsured and meet financial requirements. CDH is known for our expertise in vaccinations and our education around the risks, benefits, and we offer the vaccine information statements prior to vaccination for all vaccines, including COVID-19, that discuss the risks and potential side effects of vaccination. And these are required by federal law. Here at CDH, we allow autonomy for our patients and parents to choose what vaccines that they want to receive. And we provide vaccine opportunities for people who are unable to obtain desired vaccines at other clinics or pharmacies within our communities. So currently, in our community, vaccinations for these populations are very limited in supply, and CDH is one of the very few places where patients, families, parents can choose to come and receive these vaccinations. Patients are often coming to us requesting the COVID-19 vaccination. And since 2000, so next slide, please. So since July 1st of 2024, these are our current data on which COVID-19 vaccines we have given. So 142 were given to adults who are uninsured or underinsured. 82 were VFC, which is the Vaccines for Children's program. 92 were privately purchased or district supplied vaccine. Under 18, vaccination occurred in 97 individuals ages 19 to 65. It was 198 individuals, and age 65 plus was 20 individuals. And then on the slide, it shows what our current stock or supply is. In the past several years of offering COVID vaccine, we have not received reports of any significant harm or severe illness or injury. And I had our staff who look at our data tracking. Since we've been offering vaccine in over 2,600 vaccines, we have not had any reports of severe illness or injury to those individuals whom we have vaccinated. Thank you. Thank you, Dr. Much.
So in closing, we just strongly encourage board members to consider the opportunity that members of our community have to obtain vaccines here, which is not, which may not be available anywhere else in our community, and also to continue allowing them to have that choice and to be able to make that for themselves again. Thank you very much.
Questions?
I have a question for Dr. Mudge. You alluded to natural immunity. It's my recollection that there was a time where natural immunity was highly touted. And, Dr. Fauci is on video making a pretty prominent claim to that effect 10, 12 years ago. I'm aware of some studies that show that natural acquisition of a virus initiates through the mucosal lining, the IgA priming of the immune system to the totality of the viral protein profile. So, I think COVID-19 had 19 proteins in it. And when we acquire that, naturally, the body's immune system mounts a response to all those invader proteins, not just the dangerous pathology causing spike protein. And I believe there are studies that show that people that have had exposure to prior COVIDs of whatever kind come pre-primed with immunity as a result of that building the profile, antigen profile to those other proteins. Would you speak to that concept that somehow the shot and its singular focus on the spike protein is more effective than the natural pathology or the natural course of events in building that human immunity?
Chair.
I don't know if I can speak to the specifics of that. We do have Dr. Blue, who's an expert in infectious disease here. I do know that we have very similar lasting immunity, both from the vaccine, potentially even longer from the vaccine than from a natural infection. And the vaccines prevent the significant illness and death at a higher rate than having had a prior COVID infection, in my awareness in the studies that I've seen.
Dr. Bloom?
Mr. Chairman, board, just to speak to that a little bit, I think what the natural immunity that you speak of, if you survive the infection itself, does leave you with some good immune response to that variant. A lot of the studies also call the hybrid immunity, which is a vaccination after surviving your initial COVID, which does give you sometimes a broader breadth of immunity than vaccination alone. And so, there is a lot to that. And the different proteins, like you speak of, have a lot of different functions. They may not necessarily prevent, future infections.
Very good. Thank you for your input. Any other questions?
Mr. Chair, to the question about the infection causing more myocarditis than the injection, are you aware of the Scandinavian study that countered that significantly? They looked at millions of patients, and I know that point comes from our CDC. However, if you go into the data sets, the shot is shown massively to cause more myocarditis than the infection proper. And the Scandinavian study millions of patients, and they confirm that in their data sets. I'm just wondering if you're aware of that. Data set out of Scandinavia was a recent publication a couple months back.
Sure. Thank you very much. I am not aware of that specific study. I have seen other Scandinavian studies that were very much in line with the data that I shared today. Also a very recent study out of the UK, 47 million participants, where they showed significant decrease of cardiac events, including myocarditis, pericarditis, for the vaccinated population versus the non-vaccinated, including Spain and a lot of other countries.
Thank you. And to the point of the mild myocarditis, I know that also has been, a talking point. There was a large Swiss study that looked at patients who had myocarditis, and then they did MRI scanning and showed in those young patients that 6 months later, they had scarring burns. And half of those patients in that study, even though the myocarditis was considered mild or even silent. And so that's just a concern, is long-term, even though the myocarditis clinically, is treated with steroids or colchicine or whatnot, still long-term, there's some scarring side effects, as well as a interesting Japanese study that showed micro, almost Swiss cheese infarcts of the heart tissue after the injections as well. And so I know there's going to be a lot of kind of back and forth at this point, that point. I super appreciate that. But there's a lot of data out there that doesn't get the headline attention or doesn't make it into some of the larger government recommendations per se. I think just from I appreciate your presentation. I'll save my comments till the end, but thank you. Thank you for that.
All right. Thank you, Dr. Mudge and Savannah. Are we queued up and ready for one list? Okay. Dr. Nekrachea asked to have 5 minutes.
Hi, good morning. Can you hear me okay? Can you hear me? Hello? Yes, can you hear me? Can you somebody give me a thumbs up? Okay, great. Sorry. Thank you very much. This feels like the greetings since the pandemic. Can you hear me now? Good morning. Thank you very much for the opportunity to speak. My name is Alejandro Necochea. I'm an internal medicine physician. I work in the Treasure Valley in our hospitals in Boise, Meridian, and Nampa. And I also help triage virtually patients throughout the area that is covered by the Central District Health, including McCall, Cascade, Elmore County, Emmett, etc. So thank you again for this opportunity. I am also the chair of the Idaho Medical Association Public Health Committee. I trained in public health and preventive medicine. I will actually read a statement that I think is part of it. A version of this is included in your packet, but again, thank you for your time. I believe that Idahoans are capable to make decisions that impact their own health in conversation with their healthcare providers. This is why I'm deeply concerned about the board's upcoming vote that could remove the COVID vaccine from its clinics, allowing others to make the medical decisions for our residents. When the pandemic broke, we did not know much about this virus. My colleagues and I did what we could with the information we had. We tried masks, multiple masks, cloth masks, N95 masks. We actually even used hydroxychloroquine for a period of time until data showed that it did not help. We had hard conversations at our patients' bedsides, including withdrawing life support measures. Our public health colleagues, there's public health professionals at the state and health department levels, did everything they could to help educate the public, track cases, and get us and vulnerable people like nursing home residents personal protective equipment. We all made difficult decisions, but the ultimate goal was to do what we could to protect the people's lives, the lives of people in our care, and also to protect our healthcare capacity. When the vaccine became available, we were actually relieved. It worked to protect us and to protect our patients. In the months after the vaccine became available, we could actually see its effects in protecting people from the more serious manifestations of the infection. During COVID peaks, over 90% of the patients with COVID in our hospital ICUs were unvaccinated. It was heartbreaking to see the suffering of those patients and their families. Also, like with any treatment, there was a small number of patients who had sometimes serious side effects from the vaccines, and my heart goes out to them as well. With the worst days of the pandemic in the rearview mirror, we are seeing a resurgence of the anti-COVID vaccine campaign. Many proponents leading the push for this vote have unfairly attacked the integrity of public health professionals, like the dedicated staff of the CDH. They have compared physicians who recommend the COVID vaccine to Nazi war criminals. We have seen presentations from out-of-state actors many times by now. Their slides include an avalanche of complex medical concepts, each of which would require a focused discussion to explain. The presentations are more effective in bamboozling the audience rather than educating. In fact, so overwhelming was their presentation at the Southwest District Health Board in October that the board also banned the conventional Novavax vaccine, even though all the testimony was against mRNA COVID vaccines. In this context, frankly, I think it is difficult for the board to fully weigh the medical risks and benefits of the COVID vaccine. Instead, the vote before you is whether to take away from the citizens of the 4 counties you serve the freedom to choose what is best for their healthcare. Since the Southwest District Health vote last October, health district clinics there have had to turn away people who wanted to get the COVID vaccine. They have also had to turn down opportunities to help offer the vaccine to residents of nursing homes who may want it. As a safety net provider, it is important that the CDH be able to offer these vaccines for residents who want that protection today and in the future when we may see more dangerous strains of the virus return. There are patients in our community who are immunocompromised, who have chronic medical conditions, who are on tight budgets, and who want to get this protection. Please do not take that choice away from them. Thank you very much.
Is that the end of your comments, Dr. Necochea?
Yes, Mr. Chairman.
Questions for Dr. Necochea?
Mr. Chair, in terms of Novavax, the FDA recently made a comment to Novavax that they do have to re-enter their trials, even though it's a protein vaccine, because their shot doesn't cover the current variant, and they were asked to go back and look at doing another trial. And just wanted to make sure that was on the record. Thank you.
Very good. Well, thank you, Dr. Necochea. Next on our presenters list is Nicholas Holcher.
Good afternoon. Can everybody hear me okay? Give a thumbs up. Awesome. I do have slides, so I will wait till those are put online. Can everybody see my slides? Is it put up there? Okay, here we go. Okay, can you go back to the beginning of the slides, please? Perfect. Okay, so my name is Nicholas Hulsher. I am an epidemiologist at the McCullough Foundation, and today I'm going to be presenting abundant evidence that does support the immediate market withdrawal of COVID-19 vaccines. Next slide, please. So a total of 450 peer-reviewed studies now demonstrate that the COVID-19 vaccines are fundamentally harmful due to widespread biodistribution, persistence, and the pathogenicity of modified mRNA, the resulting spike protein, and their lipid nanoparticle delivery system. This resulting spike protein now has been shown in 320 studies by itself to be pathogenic by itself. It's now found in individuals up to 709 days after last injection. So lipid nanoparticles carrying modified mRNA travel to all organ systems, instructing them to become toxic, full-length, pre-fusion stabilized spike protein factories. Product mRNA and resulting spike protein are found directly in affected tissues at autopsy. So when they look, they do find these vaccine components in damaged tissues in the deceased. Recently, a study by Ota and colleagues out of Japan looked inside the brains of hemorrhagic stroke patients who received mRNA products. They did find that this vaccine spike protein was being produced in their cerebral arteries for 17 months, up to 17 months after their last vaccination. And this was accompanied by immune system CD4 and CD8 cells, which indicates autoimmune attack on their own brain. Postmortem analyses of 325 peer-reviewed autopsy reports does indicate a high likelihood of a causal link between COVID-19 vaccination and death involving multiple organ systems. Along with VAERS, 12 studies, or more than 12 studies now, we've actually identified over 30. We're working on a peer-reviewed paper right now, but for now, for these purposes, we'll say we have greater than 12 studies that demonstrate mass COVID-19 vaccination has actually led to increased mortality. The total number of COVID-19 vaccine deaths worldwide has been estimated to be 17 million. That's a study by Rancourt and colleagues. Another notable study here is by Alessandria and colleagues, who found a 37% life expectancy reduction during the follow-up period of people who received 2 or more mRNA doses compared to the unvaccinated. And by the way, that study had about 300,000 individuals in a large sample size. So now we look at the VAERS system. The total number of COVID-19 vaccine deaths reported to VAERS, which is about 37,000, have far exceeded recall limits of past vaccine withdrawals by up to 375,000%. In 1955, the Qatar polio vaccine was immediately recalled after 10 deaths. The swine flu vaccine of 1976 was recalled after 53 reported deaths. And in 1999, the RotaShield vaccine was suspended after 15 cases of just bowel obstruction. So quite clearly, the criteria for an FDA Class 1 recall, which applies to, could you go to the next slide, please? Next slide. Next slide. Next slide. Yeah, sorry, I went through those. Okay, so now we're here. The criteria for an FDA Class 1 recall, which applies to products with a reasonable probability of causing serious adverse health consequences or death, has been far exceeded. Next slide, please. Greater than 6 studies now have demonstrated that COVID-19 vaccination actually ends up resulting in an increased risk of SARS-CoV-2 infection. Once the initial efficacy, estimated efficacy wears off, you're left with decreasing efficacy until it reaches the negative range. This was seen by a Cleveland Clinic study by Shrestha and colleagues. They found the risk of COVID-19 actually increased with the number of vaccine doses received. 1 dose increased the risk by 107%, and those with 3 or more doses actually faced a 253% higher risk of infection. Feldstein and colleagues looked at children vaccinated with Pfizer. They were 159% more likely to be infected, 257% more likely to develop symptomatic COVID-19 compared to unvaccinated children without prior infection. Next slide, please. So we now have greater than 11 reports from independent labs across the world that have found DNA contamination in COVID-19 vaccines. This is across multiple manufacturers, vaccine platforms, geographic regions, with levels exceeding regulatory thresholds by up to 65,000%. The limit there by regulatory agencies is 10 nanograms per clinical dose. So these far exceed the safety limit that's been put in place. The discovery of large amounts of residual plasmid DNA, including spike coding sequences and the SV40 promoter enhancer in COVID-19 vaccine vials, raises serious concerns about potential genome integration, prolonged spike protein expression, and carcinogenicity. Next slide, please. We now have found that there has been widespread and unified calls for market withdrawal of COVID vaccines. There are over 81,000 physicians, scientists, researchers, and concerned citizens collected across various petitions worldwide, 240 elected government officials, 17 professional public health and physician organizations, 17 Republican Party county committees, greater than 6 scientific studies now. That's an old figure. And 2 state Republican parties have all called for the market withdrawal of COVID-19 vaccines due to serious safety concerns. Next slide, please. This is the last slide. In conclusion, I do expect calls for an immediate moratorium on COVID-19 vaccines to continue to increase until a critical mass is reached and the products are finally removed from the market. Excess mortality, negative efficacy, and widespread DNA contamination associated with these products have been sufficiently demonstrated. The FDA's criteria for a Class 1 recall have been far exceeded. No large-scale, conclusive, randomized, double-blind, placebo-controlled trials have demonstrated reduction in infection transmission, hospitalization, or death as primary endpoints. Thus, the COVID-19 vaccines are not proven to be effective in reducing important outcomes. This is especially relevant with booster products, which are not properly tested in humans before rollout. They're tested in about 10 mice. Sometimes they don't even test them in the mice, and they are approved for human use. A position supporting COVID-19 vaccination goes against good medical practice and violates the Hippocratic Oath to, above all, do no harm. Immediate removal of these products from the market is essential to prevent further harm to fewer than 20% of the population that are still receiving booster doses. Thank you for your time.
Any questions for Nicholas? Anybody? Our next presenter is Dr. Christina Parks.
May I be heard? I have a series of slides as well. Thank you. My name is Dr. Christina Parks. I have a PhD in cellular and molecular biology. This uniquely qualifies me for understanding this technology. This is actually what I was trained in. And so when these came out, I immediately recognized it as gene therapy technology. They denied it, and now that is widely accepted. Both the J&J, the AstraZeneca, as well as the Pfizer and Moderna, which are the mRNA platforms. I'm here to testify. I want to be very clear in mind. I don't want to complicate it with a lot of technical details about what is at stake and what is critical here. This is not about whether there should be a vaccine and whether people should be able to receive a vaccine. This is about the fact that this genetic vaccine technology is not safe. Now, I know for the Novavax, it still caused myocarditis, so that's a separate conversation. But this genetic technology is not safe. And if there were liability, whereas the manufacturer or the government were liable for any injury over this period of like 20 years after the vaccine, that would be one thing. But in the absence of product liability, it falls to you to ensure the safety of your citizens. And that's why we're here. If there were another route by which their safety was ensured, then we wouldn't be dealing with this. Next slide, please. So the need for an informed consent is critical here. And there are very few people that really understand this very complex scientific technology. So we need to be asking whether our healthcare professionals have the information they need to adequately understand and explain the risks versus the benefits of this new genetic technology. And to my mind, they really don't. Next slide, please. So traditional vaccines do not force the cells to make a viral protein. So on the left, you see a traditional vaccine where you're injecting a viral protein or part of a protein and an antigen. It may cause some sort of reaction, but eventually the body usually deals with that and it moves on. In a gene therapy vaccine, if you want to call it that, is very, very different. What you are doing is actually using nanolipid particles to deliver this genetic information to the cells. Once that genetic information gets inside the cell is turned into a manufacturing plant for the protein. In this case, it's a manufacturing plant for the entire full-length spike protein, which is what caused most of the deleterious effects of COVID. And so it is made in the nucleus. It is made in the mitochondria, where it really disrupts energy production. It is put on the cell surface, which was the intent, but is also secreted into the blood where it can go to other organs. So because it's a foreign protein, the body is going to attack any cell making this viral protein. This is a key reason why this type of technology is not safe, and it needs to be sort of recalled or moratorium put on it until it is better established and tested, I would say, over a period of probably about 20 years. So this is an argument whether there should be a COVID vaccine or whether people should be able to receive it. It's whether this technology should be promoted or allowed to our citizens in the absence of any liability. Next slide, please. So the goals of gene therapy technology, and so this is why it was very surprising that they used this technology, are to get the target genetic material into as many cells of interest as possible. This is not necessary for a vaccine. It's also to get the mRNA to be expressed for as long as possible, because generally you're trying to have a therapeutic effect. Again, this is not necessary, but it wasn't changed in these vaccines. It still is a goal, and it is still what they do. A previous presenter said that the RNA breaks down over a few days. That is true for your natural RNA, but this is stabilized RNA with pseudouridine, and it is stabilized so that we know that in 60 days, it is still in the cell, and it is still directing the cell to make spike protein. There's other studies that implicate it for even longer periods. So this is not a surprise because it's a goal of gene therapy. That's why this technology is not appropriate for use as a vaccine. It also has as a goal to express as much of the target protein as possible. If it were a therapeutic protein, you could understand why that would be necessary. So again, none of these are necessary for the efficacy of a vaccine. Next slide, please. The known risk of gene therapy technologies are cancer, hyperinflammation, immune system dysregulation, autoimmune disorders, genomic integration, where this genetic information actually gets inside your DNA and can be passed to your children. So the regulatory guidelines for gene therapy technology require 10 to 20 years of surveillance to pick up signals for cancer and autoimmunity. Careful screening for genomic integration into germline sex cells. Careful screening for increased prevalence of blood disorders and cancers such as leukemia and lymphoma. Next slide, please. Genetic vaccine technology causes the body to attack itself because the cells are making a viral foreign protein. Thus, this technology is not proven safe for general use. Long-term 20-year safety studies and manufacturer liability are a must. And my last slide, please. Specifically with regard to the spike protein is the inflammatory toxic part of the SARS-CoV-2 virus. And we have just made the body a manufacturing plant for the most problematic part of this virus. So your cells if any foreign protein, your immune system is going to attack those cells. And that's what we see in myocarditis. That's what we see in a lot of this injury. The immune system is destroying the cells that are making the spike protein. But if those are your heart cells or your kidney cells or cells that you need, that becomes a problem. While there may be an acute injury leading to death from this vaccine, that's not the only problem. This is going to become a problem because we've seen spike protein in patients up to 2 years out after receiving the vaccine. And so this chronic production of a foreign protein results in chronic immune activation and eventually this dysregulation of the entire immune system. And we don't have long-term studies on that. All of this promotes runaway inflammation, which is a major driver of disease, especially cancer. Thank you.
Dr. Kirk Milhone is next. Skip on to Dr. Kim Bass. You have your 5 minutes.
Can you hear me? Okay, I as well have a slide presentation. With the interest of time, I'm going to read off what each slide describes. If anybody has any questions, I can elaborate after my presentation if I could get my slideshow going. I don't know if is it up? I don't see it.
Doctor, it doesn't appear that we received the slide deck in time. So would you verbalize your testimony and maybe we can fill in with some questions the best you can, please?
Yes. So my name is Kimberly Biss. I'm a board certified obstetrician gynecologist and have been practicing since 1998. If you include my residency training, I've been involved with the care of over 8,000 pregnant women of a very diverse background and medical comorbidities. I'm speaking on my own behalf and not representing my employer nor the hospital on which I'm a staff in good standing. The timeline of these injections getting the recommendation in pregnant women is as follows. The original Pfizer trials did not have any pregnant patients in them. Men were recommended to not have intercourse, and if so, were to wear 2 condoms, and women were to be on an adequate form of birth control. The Pfizer aftermarket data was not reassuring, showing a high miscarriage rate initially of over 80%. In July, despite not having any long-term study on these products in pregnant women, the Society for Maternal Fetal Medicine and the American College of Obstetricians and Gynecologists recommended that every woman thinking of getting pregnant or breastfeeding receive the COVID injections despite any safety data. Even in Comirnaty's package insert, which was approved in August of 2021, they state they don't have enough data to say these are safe and effective in pregnant patients. Tom Shimabukuro and et al. Published an article in the New England Journal of Medicine in June of 2021, which was addressing the V-Safe data, showing that these were safe in pregnancy because the miscarriage rate was normal at 13%. Narrett et al. Has shown that a normal miscarriage rate is 5 to 6%, and I will tell you clinically that's even higher than what I've seen in private practice. The miscarriage rate in his article was quoted to be 13%. The math was not correct. They used the wrong denominator, and when the correct math was utilized, the miscarriage rate was actually 82%. This is concordant with what was found in Pfizer's aftermarket data. There was a subsequent aftermarket data set that ran from July until December, showing a 21% miscarriage rate, as well as fetal deaths and an increase in fetal anomalies. The randomized control trial that Pfizer was going to perform on pregnant women following those babies up to 6 months was halted because had they had one more congenital anomaly in the data set, it would have been statistically significant, showing harm to fetuses in women who receive these injections. The guidance today is correct, as was previously recommended by ACOG, that we still inject all women who are pregnant, thinking of getting pregnant or breastfeeding. Literature has shown that these injections do not stay in the arm. The lipid nanoparticles go throughout the body. They're fat, and that's what endocrine glands like. So these concentrate very heavily in endocrine glands, specifically the testes and ovaries. The messenger RNA has been found in both umbilical cords and placentas, which means this is not staying in pregnant women's arms. Every component of these vaccines is going into the babies. We've also found with 2 studies that fully intact messenger RNA or modified RNA and vaccine RNA is found in human breast milk. And if you look at our VAERS data, there have been babies that have been infected by breast milk they consume from vaccinated mothers. Miscarriage rates and infertility have increased in my practice. I presented my data to members of Congress in the fall of 2023. I went back and tabulated my data from 2020, January, all the way till November of 2022. In 2020, I had a normal miscarriage rate month to month of 4%. I had a normal entry of first trimester pregnant women, and I had a normal birth rate and delivery rates when you compared to previous years. In 2021, my miscarriage rate went up 100%, month to month went 8%, and it was highest in November of that year, probably related to the booster. In 2022, my miscarriage rate went up to 15% on average month to month, and in December of that year, the miscarriage rate in my practice was 27%. In January and February of 2023, my miscarriage rate was as high as 30%, and then started to decline back down to normal rates, which it remains at to this day. What's concerning in that situation is that the majority of my patients received their injections in 2021. Very few had 4 or more injections. The majority of my patients received Pfizer at 80%. The remaining were Moderna, and I had a handful that received J&J. So the majority of my patients, 65% of them, did elect to get these injections, miscarried beyond the years that they were receiving these injections, which suggests that there's something that's remaining in the systems that's allowing these women to have miscarriages. I not only saw miscarriages increase, but everything that's bad with pregnancy increased. Preeclampsia, preterm delivery, low fluid around the baby, increased rate of postpartum hemorrhaging, and some various other things. We've also done a study on which I'm an author peer-reviewed, looking at 35 adverse events in pregnancy that were reported to the VAERS system. And if you single out miscarriage and compare the COVID injection to flu vaccines going back to 1990 in the VAERS system, you're 114 times more likely to have a miscarriage if you receive a COVID-19 vaccine as opposed to a flu vaccine. I'm requesting, we don't start immunizing children with these COVID injections until they're 6 months of age. Children begin in the womb. These injections do not stay in pregnant women's arms. All the products go to the fetuses. And I am concerned, just like with diethylstilbestrol, we're going to see a multi-generational problem, specifically knowing now that there's DNA in these injections. And I am requesting that these be removed from the market. Thank you for your time.
Thank you, Dr. Biss. Any questions for Dr. Biss? All right. If not, we're going to move on to Sasha Latipova. And we'll have you take your five minutes and
great. Thank you.
Go.
Oops. Thank you very much. I only have 3 slides. My name is Sasha Latipova. I have over 25 years of experience in pharmaceutical research and development for drugs across all therapeutic areas. And I have extensive experience interacting with FDA and other global regulators, especially with respect to safety data assessment for different products. I do have experience with mRNA technologies when they were in development. And as somebody mentioned at the beginning, these mRNA technologies have been around for 20 years. That's true. They have been around for 20 years in development and all failed. None of them reached the market because they were never able to meet the safety standards. And that's important to understand. The only product that was approved before COVID shots in the mRNA, or let's say RNA category, was a short interfering RNA product Onpattro, which is a much different product. It's a very short sequence of RNA, and it was indicated only for severe, rare genetic disorder, which is disabling, life-threatening, and there were no other options. So it's not true to say that these technologies have been around. They have been around and failed. And my colleagues have demonstrated in over 400 studies how exactly that failure occurs. Unfortunately, all of that has to do with now millions of people suffering from damage. So let's go to the next slide, please. Please click through. I'm sorry, there's an animation here. Yeah, for several times more. Next, 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 and next, and next, and next. Sorry. Yes, okay. So I am going to speak about regulatory aspects and legal aspects. And I would like you to understand this as quickly as I can present, because this is crucial for understanding why no regulatory action has been taken, even though there is undeniable evidence of massive injury and deaths related to these shots. So we need to understand that these products are not actually regulated medicines. They are EUA countermeasures. And this is not at all like a normal pharmaceutical regulatory pathway. So here on one page, I have all the regulatory pathways that exist in the United States. There are 3 that are investigational, which is what everyone understands normal pharmaceutical products go through. And the product can be approved on market. And it still remains investigational because continued clinical trials can be taken on this product. So it can be still in clinical trials and be investigational. Or patients can get access to it through expanded access use, or otherwise known as right to try. It's still investigational. And all of these products must comply with all pharmaceutical regulations, such as generally called CGXP, good clinical practices, manufacturing practices, laboratory practices, and distribution practices. So all of that compliance is required. Now, when we have an HHS declared emergency, such as COVID emergency, which is still currently ongoing and extended by the outgoing HHS Secretary, Javier Becerra, to last until December of 2029, so a full decade of emergency that we're having right now. So under those conditions, we have what's called PrEP Act invoked, and these products become EUA countermeasures under PrEP Act declaration, and they stay that way. And EUA countermeasures pathway is completely different. In fact, it has a separate chapter of Food and Drugs and Cosmetics Act, and this federal law essentially makes everything that's illegal for normal pharmaceutical products fully legal for these products, for EUA countermeasures. So it waives all manufacturing compliance. That's why we have massive DNA contamination and no regulatory action. And there's massive contamination with other things in these shots as well. DNA is not the only contaminant that was found. We also know about massive non-compliance in good manufacturing practices. In fact, both Pfizer and Moderna supply chain has been finally audited by FDA, found non-compliant with CGMP, and no regulatory action was taken. In addition, these products can be adulterated and misbranded. Misbranded meaning you can lie about them freely and it's legal. So these are the aspects that healthcare providers must understand as part of informed consent disclosure. So let me also walk you through the PrEP Act a little bit. Let's go to the next page, please. So the EUA countermeasures, as I said, are exist under PrEP Act declaration, and I also forwarded a legal memo to the members of the committee so that you have all the citations to law and explanation about the EUA countermeasures in detail. It's only a couple of pages long. So the patients need to understand, and the healthcare providers need to understand, that the only venue for injury compensation is a countermeasures injury compensation program. That's why no matter what FDA says about the full approved status and community and so forth, by law, these products are still EUA countermeasures because you can't get any compensation otherwise unless you go through the injury compensation program for countermeasures. Courts have adjudicated so far unanimously that PrEP Act liability shield for manufacturers exists for these products. So they're not liable for death or injury at all, which again confirms that they are indeed EUA countermeasures under public health emergency and nothing else. Peter Marks himself, former head of CBER, testified in court that because of theoretical self-asserted possibility that Pfizer and Moderna can manufacture so-called FDA compliant batches, then vaccine administrators were instructed not to provide informed consent. And thus the EUA versions, the countermeasures were pushed on people as if it is a licensed vaccine, and it's not. The licensed vaccine was never made available in the United States. In addition, for the countermeasures, no institutional review board, no informed consent rules apply, and they are not subject to any FDA evidentiary standards for safety and efficacy. In fact, the only standard by which they go on the market is a maybe effective opinion of HHS secretary. This opinion is non-reviewable by Congress or by courts. And maybe effective, by the way, is not a regulatory standard of any sort because maybe effective can be also maybe toxic and maybe lethal. In addition to all of this, there is no mechanism for FDA to recall these shots. So while the class 1 recall standards have been plentifully satisfied with these products, FDA has taken no action because there is none prescribed in law for EUA countermeasures under public health emergency until PrEP Act declaration is terminated. So, in the absence of any enforceable consumer safeguards, make these products potential poisons with no mechanisms to rectify. This needs to be part of the informed consent disclosure because also the EUA law and the PrEP Act law makes it a requirement for the healthcare provider to disclose all known risks with these products. And certainly, the risk of you not getting any compensation, or the risk that somebody can be lying to you about this product, or the risk that the product can be freely adulterated is actually a valid risk of harm that people need to understand. So I highly recommend that if you still provide these shots, you should include these disclosures into your informed consent paperwork. And let's go to the last slide, please. So in addition to speak a little bit about the PrEP Act. So PrEP Act is the federal law that is being misused and abused in introduction of these products. When it was introduced in 2005, it received very serious constitutional challenges. And I'm quoting the letter here that was sent to Congress by Edwin Chmerinsky, discussing how this act violates First, Fifth, Seventh, Ninth, and 10th Amendments of the US Constitution. It introduces unchecked executive powers. As you can see, HHS Secretary essentially has a power to declare a public health emergency. No data is needed to justify it. And his decisions are unreviewable by Congress or judicial branch. So clearly, this is an usurpation of power by executive branch. The abuse of emergency powers by this law is because this law was never intended to make emergency declarations as a permanent loopholes to ship millions or billions of doses of mass consumer medical products. But this is exactly what's going on right now, and they're planning to continue until end of 2029. The law gives blanket legal immunity to anyone, not just the manufacturers, but any administrator of the vaccines, anybody along the supply chain, as long as they're following HHS orders. So thus, just following orders has been made legal defense in the US law. And the failed compensation program, finally, so the countermeasures injury compensation program is a complete black hole. It's completely unfunded. It's not funded adequately at all. It has compensated only a handful of people for very little money. There was one large award, but a handful of very small ones. And to enter this program and to try to claim any compensation, people are required to waive their constitutional rights. The decisions are made by a secret committee that that reviews the medical records based on secret criteria. And as I said, it funds almost nothing. So all of this needs to be taken into account by your committee when you're thinking through what implications this misuse of this federal law has on citizens of Idaho. And are you properly disclosing this information to people who receive these shots? Thank you very much for your attention.
Any questions? The next presenter is Dr. Figueroa. Are we? Oh, he's in person. Oh, okay. If you'd like to take your few minutes, 5 minutes, we'd love to hear what you have to say.
So my name is Javier Figueroa. My doctorate is in neurobiology and behavior. I graduated from the University of Washington from the School of Public Health and the Department of Environmental Toxicology. I have extensive experience in molecular biology, cell biology, neurobiology, and toxicology. I also have a bachelor's degree from microbiology from the University of Washington, University of California, Davis. I've been in the field of clinical trials and basic research for now over 20 years. And I'm here to testify and to inform the health district here that these shots, as all the expert witnesses have stated, are really, well, they are under PrEP Act, meaning that they have absolutely no requirement under FDA regulations to actually adhere to any standards. One of the reasons that we haven't seen the increase in deaths prior to this is that the manufacturing practices are so bad that we can't even guarantee that we have an effective product. mRNA nanolipid manufacturing is still in its infancy. The technology does not allow for any sort of quality control on the stability of mRNA product. That is, you get injected, living out of artificial delivery, but you'll have fragments and you won't have complete mRNA. You do, of course, there are also the other options and the problems associated with have that other issue to adhere to as well. This is something else that needs to be addressed because this is under a PrEP Act, the Public Health Emergency Declaration. It is up to each and every state, district, county health board to guarantee the safety of these products, especially during these emergencies. This is at the heart of it, especially with a new technology like this. This is a dangerous technology. We don't know how long it resides in the human body and whether or not spike protein fragments can actually shed, which was a concern that Pfizer and Moderna both stated in their clinical trials. So for all we know, this can continually be produced by a small fraction of patients and spread through this shedding characteristic. So that's something else we have to consider. The issue at hand is one of making something available to doctors to distribute to their patients in order to counter these infections. Again, the choice is not about providing a product. The choice here is about ensuring informed consent to those patients. Now, I know that there's many dueling clinical trials and studies showing, no, we don't see an increase over here, but there are few important studies that do show an effect. Here's the critical part of all of this. In science, if you have one event that counters any other, you have to start taking it seriously. For the sole reason that these swan events, these black swan events, indicate that there is a signal strong enough to get through the barrier. Problem, of course, is that we do have an industry here that wants to ensure that public health is respected and that there is assurance to the public that they are looking out for you. But there's a problem there as well. There's so many interests associated with this. How many hundreds of billions of dollars are at stake and in line here for this technology? We're looking now at trillions of dollars that could potentially be made by advancing this technology as well. So there should be a consideration of conflict of interest, which is something that doctors, prior to the involvement of the allopathic medical approach and the drug approach, took it quite seriously. There's so much money being deployed, conflict of interest need to be considered. Also, it is the responsibility of the districts here to actually start looking at each of these individual batches as well. I would urge that each and every one of the health districts here do take a sample, do start looking at lots, start running their own analyses instead of relying on the private sectors, these individual patients, these small foundations that have taken the time to actually look at these files and have found this on their own. These are private individuals, not governments, not local governments that haven't done this. They need to start doing it. And I think, based on the evidence so far, you start doing this yourself, you will be shocked. Shocked at the fact that the contaminations are real, shocked that you don't have a product that works, and shocked that the dangers that you're putting your patients and the people that you give this to is far greater than the benefit or the theoretical benefit that they will receive from this. We're now into 5 years of this particular emergency. It's no longer an emergency. We have the means, we have the methods, we understand how this disease works, how it spreads, and how to contain it. We have the ability to sending out a technology that's untested, untried, and now shown to be quite dangerous. It's a responsibility that has to be adhered to by all the health districts in the United States, here in Canada. I left Washington State because now the push was to mandate these shots. I lived there for 25 years. I had colleagues, friends that are injured and died, that believed and trusted in this health district. And then knowing and seeing all this, I begin to realize that you're also victims because you are being treated like mushrooms. And don't ask me to explain how you're being treated by mushrooms. It's a pretty crude joke, but you're being kept in the dark. You're being fed. So again, thank you so much. I know this is a lot to consider. There's a great deal of pressure on you, both from your patients, your doctors, and your hospital systems. But there is a time that has to be addressed here. Thank you.
Very good. Thank you. Any questions? Do we have Dr. Milhone on?
Chair.
I'm asking.
Oh, I'm sorry. I thought you were asking
Yeah.
me. Sorry.
Peter McCullough is on.
Oh, he's in the waiting room, yeah.
In lieu of Dr. Milhone, I'll offer 5 minutes to Dr. Peter McCullough.
Thank you. Can you hear me okay?
We're at the tail end of our presentations. Thank you for joining us. If you are willing to share 5 or 6 minutes with us, that would be great.
Well, thank you. I'm Dr. Peter McCullough. I'm in practice as an internist and cardiologist in Dallas, Texas. Also a frequent commentator in the media. I've testified in the U.S. Senate and the House of Representatives on many important matters through the course of the pandemic. I've been very active clinically as well as academically in the area of COVID vaccine myocarditis, or heart damage caused by the COVID-19 vaccines. And so I've seen and examined now several hundred patients with myocarditis. And I can tell you, I am very concerned that the vaccines cause not only initial acute heart damage, primarily in young men, but also long-term. They contribute to progressive cardiovascular disease, both coronary artery disease, arrhythmias like atrial fibrillation, serious arrhythmias like ventricular fibrillation. And the most serious development of all is cardiac arrest. And recently in the Journal of the American College of Cardiology, 3 autopsies were published on Japanese people about my age who took 3 or 4 COVID vaccines and had what's called microscars in the heart. This is something that never would have shown up on an EKG or cardiac MRI. And sadly, they had cardiac arrest and were not able to be resuscitated. At the McCullough Foundation, we've done an analysis of the city of Seattle, which is 97% vaccinated. And as the vaccines rolled out, cardiac arrest began to skyrocket in Seattle, both the frequency of the cardiac arrest as well as the lethality of the cardiac arrest. The COVID vaccine cardiac arrest do not seem to be as resuscitatable as other forms of cardiac arrest. You may ask, well, what can we do about it now? Is water under the bridge? About 80% of Americans took the vaccine. Thankfully, 20% didn't. As a cardiologist, I can tell you I did not take the COVID vaccine. It was never safe enough for me or my family or my patients. There's no way. They're genetic, Pfizer, Moderna, and Janssen, and they install the genetic code for the dangerous and lethal heart-damaging spike protein. But what we can do about it now is we should have patients who've taken the vaccine have some risk stratification, at least an EKG and an exam. I've published a paper in the World Journal of Cardiology based on what's found. Additionally, what else should be considered. We've innovated with various forms of pharmaceutical drugs and non-prescription pharmaceuticals and what's called a McCullough protocol-based spike protein detoxification. It's at least something we can do now until there's more research. But for this group, the most important message is that we can't allow any more heart damage to occur in the population. People taking the vaccines right now, they still don't know about vaccine side effects, and they're not fairly warned. The package inserts for Pfizer and Moderna do not mention fatal myocarditis. Yet there have been thousands of cases in the United States. There's 400 peer-reviewed papers on this, and the package inserts for the emergency use authorization for the booster still don't mention fatal myopericarditis. So patients and their families, and particularly children getting the vaccines, they're not fairly warned. The only proper thing to do for this group to do is to actually remove their use from the market. I'm Dr. Peter McCullough, cardiologist in Dallas, Texas. Thank you so much for listening.
Thank you, Dr. McCullough. Any questions for Dr. McCullough? All right, board members, that is the totality of our presentations and public input. The direction is at the will of the board here.
Mr. Chair, we haven't been able to hear from Dr. Blue.
Well, I think we've offered a number of times.
Would you care to testify, give some remarks after hearing that?
Do you have a question?
I'd just like to hear your thoughts on what you've heard.
Okay. Mr. Chair, and board members, and actually really want to thank the presenters for being part of, the scientific process. And, certainly, several of them have been coordinated by one of our guests for the state Senate bill that was similar to this. So, appreciate what they're doing in there, and an awful lot to unpack. And as they mentioned, a lot of these speakers are also presenting nationally where those decisions for FDA approval and things like that are made. And my first kind of impression is we all have something called a confirmation bias. When we have something in our minds, that's what we see in the literature. Dr. Cole mentioned one study, Dr. Mudge another, and everybody's throwing out 100 of these and 300 of those. And in the totality, there's a lot out there. And knowledge begins when we discover something that we don't understand. And so learning on that as well. And like Dr. Nicochia said, heart goes out to those who have injuries from the vaccine. As a practicing infectious disease physician in Idaho, my heart goes out to the families who were dying in our ICUs who wish they could have the vaccine. And, actually felt, afterwards that, when they found out there was a vaccine available and their family member died, they felt betrayed as well. And we don't have those in front of us. And so with that, one sort of thing that I haven't heard discussed, and I'm, and I'm the first to say correlation does not make causation. But as we talk about COVID, the original gene therapy is the virus. You mentioned the number of proteins that the virus uses, and how it gets there is similar to the J&J vaccine that Doug Cameron received with an adenovirus. That virus is our original gene therapy. With that, it inserts its RNA. And the first protein, as you mentioned, isn't the spike protein. It's those other proteins that are in that open reading frame. And the first thing that does is to block your own immune system. From that, then those cells in the body, and sure enough, that virus with its lipid goes to every tissue in the body as well. And with that, it starts to make a protein that blocks our immune response. So it is pumping out thousands of new replicating virus for every cell that was infected. So when we talk about a vaccine that has only spike, we have to compare it to the infection itself. And what are those? And we talked about the Singapore study with myocarditis. Dr. McCullough, a cardiologist with infinite experience as well. The NCAA study looking at athletes who were infected with COVID in their MRIs. We do see that. And so at the end of the day, as somebody had mentioned, and we see this in Idaho as well, we just have passed the ability to receive ivermectin or buy ivermectin at any store without a prescription under the guise of medical freedom. So are we talking about medical freedom? As Dr. Nicochia said, we're not mandating, we're not coercing, we're offering it. We're not voting. You guys are not instructed to vote on whether it's going to be on the market or not, whether it's got FDA approval or not. You're voting, as I understand it, is to whether to offer it. And as Savannah and Dr. Mudge said, we're allowing this and offering it to those who request it, who do not have insurance and cannot get it elsewhere. You're not going to impact me, who can go down to Walgreens and buy it. You're going to impact those who don't have that choice. And so really, are we here going to sort through that massive data and the legal arguments for FDA approval and the PrEP Act and whether it's constitutionally, appropriate here for the 315 individuals that we provided this to last year? So, and as Dr. Nicochia said, to really sort through this, would love to look at the data, go through each of those, figure out how and what or it's telling us, learn from that and further our knowledge.
Good. Thank you for your input. We're at the pleasure of the board to take action on what we've heard today.
Mr. Chair, go ahead. Could I make a few comments kind of in summary of what we've heard or maybe what we haven't heard, or do you want to?
If we're going to have a motion to take action, let's put that on the table and then we'll have time to.
I would actually prefer to hear what he has to say.
I'll defer to Betty again. She had a question first. Oh, you have a motion. Okay. All right. I'm sorry again. Go ahead.
Motion's in order.
Chair, I'd like to move that we table the topic. I don't feel like I've got the knowledge to be able to sort through all that he's talking about. And I definitely don't have the power to make choices for everybody. So I'd like to still have it be available. I will second that motion.
Did you repeat the question for me?
Sorry, Jane, yeah.
Oh, sorry.
Was your motion to table this conversation?
Table, right. In the discussion permanently.
Permanently table.
Okay, we have a motion on the table. We're open for discussion on that motion.
Well, Mr. Chair, actually, as of the cutoff time yesterday, we all received 269 emails. I think 23 docs weighed in, and it was a very mixed bag. Corey said there was a number of them came in after the cutoff time. And it was, like I say, a very mixed bag. One I do want to point out is Dr. Sousa, who's we all became very familiar with during the epidemic, was one who says, please, please maintain the informed consent and the availability of those vulnerable individuals. So I totally am support of the motion because I feel like we did not have an informational session prior to this meeting. It came up after our last meeting as an action item, and we just need more time to digest this situation.
Sure. I appreciate Betty and Jane's point of view. With all the data, and Dr. Blue is correct. There's conflicting data sets out there and whatnot, and certainly a lot of emails to read through. I get that. If I could boil it down to something very simple, and what we're discussing, what we have in the fridges and freezers, with all the data in the world, whatever. But the fact of the matter, if you look at the CDC's own data set, what we have as a booster in our fridge right now that we're giving to our citizens, who we as a board are obligated to inform and protect to the best of our ability, we have something for which the variant that it covers is now, per CDC's own data, 0%. We have an extinct variant, and thereby we have an expired shot in our fridge. So even if somebody from any libertarian point of view wants to come in, if we're honest, we can say, look, the current variant, 70% of America has is LE 8.1. This was for JN1. And that doesn't exist anymore. It's gone. That's what coronaviruses do. That's why we've never had a successful shot for any coronavirus historically. And going forward, from a scientific point of view, never will. And then the other concern I do have, and I think this was a great suggestion from one of the presenters, is every laboratory in the world that has tested these vials so far has found that they're not pure RNA. They are highly contaminated with DNA from the manufacturing process. They're not supposed to have that in them. DNA in and of itself is dangerous to the human body for multiplicity of reasons. None of these products have ever been tested for carcinogenicity, for birth defects, for fertility effects. So we have an expired variant and an expired shot freezers right now of our facilities. So all the data in the world, we still have a product that has a lot of risk, but for something that doesn't even exist right now from a statistical point of view. And, if we pulled any 1 or 10 of these and sent them to these dozen labs around the world, we will find, because of the way they're manufactured, that they're contaminated with DNA that can cause countless risks. So I appreciate, again, we can argue for hours, but we have something that doesn't work for something that doesn't exist. And that's the point I kind of wanted to bring up at this point is, I appreciate everybody's point of view of what we've all tried to do for the last several years from different angles and approaches. But I think doing the same thing over and over with something that doesn't accomplish what it says it can. And it doesn't prevent disease. Cleveland Clinic showed the more of them you get, the more you get COVID. We have a product that, yeah, if we had a broken tire on a car, they get recalled. If we have a crib that breaks and kills 1 or 2 babies, we don't offer that crib anymore. If we have a product that, accidentally contained cyanide or hemlock, we certainly won't have that in our fridges and give it to anybody. So we have a product that doesn't work, that's for an expired or an extinct variant that has known contaminants. And so to protect our own citizens within our health district, I feel it's worth moving forward and considering halting, pausing, not offering it until we can prove that they're not contaminated. And they were never, quote, safe and effective. Most of the government was ever allowed to claim is maybe effective. And so anyway, I'm concerned that we have a contaminated product in our bridge for a variant that doesn't exist. Where's the CDC's own data? Thanks. Go ahead, Betty.
Once again, the top priority for me and listening to the health experts that dialed in, the patients, especially the elderly, that we do not remove the freedom of choice.
Mr. Chair. We don't, but if we have something that is not what it says it is, then we do, out of protection and out of the precautionary principle. If someone wants to go acquire their own contaminated product, that's wonderful. But if we knowingly have something contaminated, then we don't offer it. And that's, I think supersedes that libertarian principle of, informed consent and known harm and risk benefit ratios. But that precautionary principle would be, I agree with you, most choices in life leave it up to the individual 100%. But if something has something in it that you don't want in it and you're not informed that it's in it, then I think it's the better portion of caution to say, until it's safe, then we stop it.
Okay, is there any further debate on the motion to take Commissioner
Chair.
Rogers?
I feel as though I don't have information as well. Specifically, what the informed consent states on there. Because it's hard to make a decision on something that we don't even know what the patient gets. So that's something that I had written down. I also try to separate my personal views of things from community health, just because I believe in that freedom. I've been in two or three situations medical situations where I wasn't listened to by physicians and acted, my own free will and my own decisions, and I would hate to take that freedom away from somebody. So I would definitely want to see that. That's important that they are getting the information. And if it may possibly state, I don't know, as far as testing for contamination or any of that, that's, beyond me, because I don't know what that takes or what kind of resources that would take from the health district. So I just need more information.
I would agree with tabling this because it is a lot of information. I don't necessarily agree with permanent tabling this. If we get more information or process the information that we got today, and then to make a decision about this. Their next meeting's not for a few months.
Are you making a substitute?
I am not making a motion yet, but there's already a motion on it.
Well, there is a motion on the table and we're in discussion on that motion. A substitute motion.
I would say substitute motion that we table this until our next meeting. That type of process.
Mr. Chair, just a question of clarification, maybe
Rush, you would know more about this. What is our current and newly appointed administration and HHS secretary? What is their stance on this? Are they working towards something? I think this is such a national issue that's really hard to bring it down just to the Central District Health Board here. I also agree with freedom of choice. I didn't like it when people were mandated to do it. I don't know if it's our position to take it away. There's information on both sides of the table. I definitely don't have an MD behind my name. I don't appreciate it being in an industry where people second guess me. So I try really hard not to second guess other experts within an industry that I'm not a part of. So I guess, Russ, do you have any info on that, on what the current administration and his cabinet is planning?
Sure. So, Mr. Chair, so we all know who the current administration is. We know who's in charge of Health and Human Services, where the FDA is located that authorizes this vaccine, as well as the Centers for Disease Control. That's also under Health and Human Services, and they recommend the vaccine. There's a whole list of criteria and ages and which vaccine and which doses, which I couldn't possibly pretend to recite back to you. There's also a vaccine information statement to Commissioner Rogers' question that is very similar. It's as to all other vaccines that are administered, and that is always provided to the patient ahead of getting the vaccine, so they have an understanding what the risks are, what the potential side effects are, and then that's when we would administer it. So it's not something that we push on anybody. It's available through our clinics, as you've heard from others. It's often given to individuals who don't otherwise have ready access to it, or maybe access at all. So my personal opinion is, if this is a really unsafe product, as some of the presenters and Dr. Cole spoke to, the FDA needs to remove it, as they do all other medicines and vaccines, when it's shown to do harm. So I think right now, having a local board of health, of which, by the way, there's over 3,000 health districts in the United States. If you want to go district by district or county by county, board of commissioners that to vote on this here in Idaho, that's a really long process. It's putting someone like yourself without specific medical training in a decision point of, should we offer a medicine or a vaccine that's currently authorized by the United States Food and Drug Administration and recommended by the Centers for Disease Control, all headed up by Robert F. Kennedy Jr.
Mr. Chair. In response to that, so to Russ's point, it's emergency authorized and not approved. And as Sasha Vogel pointed out, it falls under the PrEP Act as an emergency product, not as an approved product. So it hasn't undergone all the rigorous safety. And again, it is. If you listen to what the FDA said last week, all vaccines going forward will be tested against placebo. The ones that are on the market right now never underwent human trials. The booster that are in Central District Health fridges only went through mouse trials. And so technically it was a new protein and a new product, but it never underwent human trials. And so there's a lot of wrangling within the administration and the different agencies. I agree with that. I still think it would be interesting to see what we have and to have it independently tested by independent labs. Again, every vial that has been tested has found contaminations. I think that would be a simple scientific thing to do, would be to take 3 Central District Health vials, different lots, and send them off. And then we would know what we're receiving in this poor manufacturing process from a bunch of different companies. So Russ is correct. It's authorized. It's not an approved product. Under an emergency that exists
until 2029 until that changes.
Mr. Chair, I have a follow-up question. I fully understand that this is under prep. I personally have done a lot of research on this. Does the current secretary not have the ability to take away that authorization?
Where that he's working.
So it's not like because it was done with the prior secretary, that authorization is permanent through 2029, or the current secretary.
It was made until 2029.
But the current secretary does have the ability to remove off this prep authorization.
I have a question. What would it take to get 3 vials tested?
What would it take to get 3 vials tested?
Timeline.
Timeline, probably about 2 weeks. We're a lab in Boston that's done many. We're a lab in Canada that's done many. We're a lab in Germany that's done many. Lab in Austria, lab in Japan. The same lot tested by 3 different independent laboratories. It would probably take 2 weeks at most.
I would be interested in seeing the results of that. That is something we can.
What is the cost? Sorry, Mr. Chair, what is the cost?
Well, all the labs that have done it so far, done it out of scientific interest. The cost is probably about $150 in terms of the primers and the sequencing run.
All right, we've got a substitute motion on the table from Commissioner Tucker. Is there a second on his motion to postpone until the August meeting?
I would second that motion if we modified the modification
Okay.
to include table it with the condition that we will take whatever we agree on number of vials, send them to 3 laboratories and have them tested. And then at our next meeting, readdress the issue.
Mr. Chair, if you're thinking along these lines, I would like the collaboration of maybe Dr. Blue, say Dr. Sousa, some of those people too. Their input also.
Yeah, I would actually like to revise my motion to include.
We're a little loosey-goosey.
The testing of 3 vials. That's appropriate. 3 vials and have that information at our next meeting.
Mr. Chair. I'm just curious. I want to make sure as the board votes that we understand the significance of what you're looking to do and how that might alter your decision. And I think Dr. Blue would probably be a good one to answer that. I don't understand this. It's contaminated. I mean, I've not heard that.
I can explain that.
Yeah, we're in discussion, so we're going to stay with the panel members during the discussion period of motions.
Okay, so here's the contamination issue. When Pfizer did their 44,000 patient trial, they used a very synthetic sequence, which they injected into 44,000 patients. At the very end of that trial, as their data sets were coming in, they realized they weren't going to be able to make as many doses as they thought were needed. So instead of doing this very synthetic production process, they took the synthetic mRNA, injected it into a bacterial culture that's used in laboratory studies of E. coli bacteria. And you use a little loop of DNA, a little circle called a DNA plasmid that has your mirror image sequence. So the DNA, codes for the sequence, and then it makes the messenger RNA. And then you use enzymes to break down that broth, purify out the synthetic RNA, wrap it in lipid bubbles, and then inject that. That's the product. So 44,000 people underwent the Pfizer trial with the very synthetic. And at the very end of their trial, they used this plasmid, this bacterial made product. They tested that on about 250 people, for which you're not going to get the safety signals that you would have from 44,000. That's the product they ended up bringing to market.
Now, over the last several years, it was accidentally discovered by a genetics lab that we're using the mRNA vials as a control, saying, hey, we need pure RNA. And they found that the vials actually had DNA in them that was supposed to have been cleaned out. mRNA, as mentioned, is supposed to break down quickly. Synthetic RNA doesn't. But DNA in a little circle most certainly doesn't. DNA can persist for a long time, can get into the nucleus of the cell, can persist in the cell, which is why some patients 2+ years later are still making spike protein. Billions of people, in all probability, got a contaminated product because of this manufacturing process. So this little loop of DNA that was supposed to have been cleaned out, depending on where it's been tested, has been anywhere from 6 to 100 to hundreds of folds higher than is allowable within a product. The FDA allows 10 micrograms of naked DNA in any product. This is hundreds of folds of that protected in a little bubble of fat. So there's not even an FDA criteria for DNA protected in a fat bubble, especially exceeding the known amount. And so that's where this contamination comes from, is the manufacturing process. And the long-term side effect of that, because they didn't test for carcinogenicity, mutagenicity, fertility impacts, nobody knows the long-term, especially with the contamination of products. Is Moderna contaminated as well? Yes, to a lesser degree. But they also have sequences in there. Here's the one more thing on the contamination. That little circle of DNA that contaminates, it has a sequence in there called a promoter region that comes from a virus known as SB40. It's a monkey virus from the green monkey. That monkey virus is a known carcinogenic virus. Now, the promoter region itself has some problems. Pfizer just literally pulled off the shelf some of their cell cultures that they use for studies and used that E. coli DNA and used that little circle template to make their RNA. But it happens to have sequences in it that are from known carcinogenic viruses, as well as other sequences that are known as origins of replication, mammalian origin of replication, that allows it to go into the nucleophore cells. That wasn't supposed to happen because it was supposed to be pure RNA, pure synthetic RNA. But instead, like I said, every vial tested so far and every lab so far has been contaminated because of this poor manufacturing process that didn't have the required regulatory controls because it was under PrEP Act. So that's my bigger scientific concern, being a laboratory nerd, is what are our citizens, whether you got a shot, didn't get a shot, I don't care. I don't care what your politics are. I care about the science. And, a lot of people got shots, a lot of people didn't get shots. But going forward, now that we know this, if we can confirm it with what we have here, then, our job is to protect citizens and make sure they get what they're informed as to what they're getting.
I guess what comes up in my mind is that we can all get whatever result we need to get or we want to get from the laboratory.
Well, the cells don't lie, and that's why you would do it with 3 different laboratories or 4 or 5 or 10. And, that's just a matter of sequencing. And if the sequence shows up, it's either there or not. In a lot of my presentations, I say, look, the cells don't lie. And those sequences don't lie. If it's there, it's there. If it's not, it's not. If it's not, fantastic. If it is, not so great news.
Okay.
I'm sorry.
Mr. Chair, I still have an issue with a little local board of health making basically a federal decision.
Okay. So we've got 2 motions. The motion to suspend until the August meeting with that condition. We've got an underlying motion to table altogether. Okay, so I would like to maybe address a couple of things as my prerogative in debating on these motions, that might answer a little bit of what you're addressing. I looked at all the emails that came through, and there were some themes. And I was a little concerned that some of the authors of the emails were conflating this one shot with the totality of the vaccines provided through Central District Health. Well, I mean, this conversation is strictly about this this product, not expanding it beyond that. As far as not being in a position or having the science background to make some of these decisions, the pharmaceutical companies spend hundreds of millions of dollars on TV ads to drive layman opinions, right? Who doesn't know about the little pill with a big story to tell, right? We're all seeing the Jardiance Dancing People commercials. A lot of investment by pharmaceutical companies is made to completely, in essence, bypass maybe the medical hesitancy. They're driving people to go to their doctor and twist arms and say, hey, I want this. That's the whole point in the direct-to-consumer marketing that only 2 countries on the planet allow, right? And so we have agency over our own healthcare decisions. This motion or this conversation isn't about removing anybody's right to seek a treatment or not a treatment. I do find a measure of irony, which seems to be fine back. Some of the same organizations that were telling us that our boss could tell us what type of healthcare procedures we're getting are now the ones championing these decisions need to be made between the patient and their provider. And I just conflicted with how now the story seems to have changed in that regard. When I was, in one of the letters, a lot to do was made about the 90% of the patients with COVID that were admitted were unvaxxed. There's a lot to unravel just in that statement alone. But at the Health and Welfare Committee, we had presentations from the hospitals, and it was during a crisis standard of care discussion. And the hospitals were struggling with staffing, partly because they had let go some of the actual medical professors or professionals that with their own license and training were making the decision not to get these products. In addition to vacancies as a result of the terminations, they admitted in that health and welfare hearing that one of the hospitals was averaging 125 employees a day out with illness. And so I probed a little bit, and of course, the illness they were out with was COVID. A population of 80 to 90% fully vaxxed employees were out with COVID and unable to fulfill their duties in the hospital. So we can say that 90% of the patients were unvaccinated, but also a majority of the employees that were out with illness were vaccinated. So there's probably some other aspects that go along with the disease presentation, whether you acquire it or you present it or how sick you get from it. And in one of these emails, they talk about we did the best we could with what we knew. Well, some of us were championing 30 years worth of nutrition and information and promoting that. And I had a bit of a hit piece written because I was talking about vitamin D sufficiency in the Health and Welfare Committee. Well, now there's a study out of the VA published in the journal Nature, and their first sentence is vitamin D sufficiency has long been associated with reduced immune function that can lead to viral infection. Several studies have shown vitamin D is associated with increases risk of COVID-19. So they go on in this study in 2022 to make it conclusively say that the greater your serum vitamin D level or the greater the supplementation, the lower the risk of morbidity and mortality from COVID. So the more you take or the higher the blood level, the less sick you get. And it's those kinds of things that are probably the reason why that patients in the hospital and vax were getting sick, or patients vax were not getting, or were getting sick, was because we're not looking at the totality of the health factors. And again, we rely on these medical opinions, and I'm not trying to be critical of, any individual's healthcare they say are in practice, but there's a whole litany of pharmaceuticals that have been removed from the market as a result of the damage that has been done. Vioxx was removed after 5 1/3 years for causing strokes and heart attacks. That was known pre-market, but they did it anyway, right? So there isn't this, we've seen ample evidence that it may be misguided to just wholly trust the opinions of others. The virus and viral presentations don't care what initials you have after your name. I pointed out at one of our board meetings 2 months ago when we had the conversation about opioid settlement money, and the irony that for 3-4 years, we had healthcare policy that censored people, threatened their licenses, destroyed their livelihoods because they weren't following a narrative. All the while, we're cashing opioid settlement checks in this state that came about as a result of the fraud and corruption by some of the very same people we were told we couldn't question. And so I think that we are in a place to have this conversation as a health board. I don't believe that everybody needs to have initials after their name to weigh in on these things. So often, just random common sense would dictate courses of action. So I am in support of, it's probably evident that I would support removing these. One of the commenters said 64% of the people in the state are vaccinated, and they're touting that as a majority of people choose this. Well, actually, probably not, because they were vaccinated at the point of a gun, threatened with their livelihoods and so forth. So how much of that organic or that vaccination rate came organically? And I really think that the evidence is quite compelling, and that we should consider or reconsider continuing to offer. But if it's the will of the board to postpone and weigh in some more on this in August, I would support the amended substitute motion to table it until the August meeting.
Chair. So for us to abide by the meeting laws, we'll have to get, so the first motion was made and seconded. We'll need to get a vote on that one. Or if Dr. Young retracts her motion and agrees to the substitution, could substitute that, but we would need to get a voice vote because it was made and seconded. So that first motion.
So we can't deal with the substitute motion? Because normally,
Unless Dr. Young retracts her motion, that makes it.
are you looking that up in Robert's rules?
I was looking at the inputs and how they stories and sure and various. You must.
Okay.
I would like to request too, if we do vote, a recorded vote.
But we'll have to vote, but, all right, then I guess we need to, according to Corey, it might be different than I'm used to, but I'm in a different environment. Address the underlying motion to table this altogether. So I think we'll close the debate on the underlying motion. All in favor of tabling it forever, say aye.
Can we do a recorded vote by county, please?
Yeah. Aye. Dr. Cole,
Dr. Cole, Ada County, no.
I'm no. Boise County Commissioner Tucker,
No.
Elmore County,
Yes.
and Commissioner Rogers.
Aye.
Aye. Okay. And Valley County, sorry.
Aye.
Carries. All right, motion to table permanently carries. That is the end of our discussion on that subject. Is it will of the board to take a quick break?
I think have moved to the bunch you would here.
Well, we'll take a, you said
Like 20.
15. Yeah. Okay, we'll be at recess for 15.
So is it out here? Oh, yeah, just to bring it in or. We have food available since we're well beyond, or well into
all done. We're actually live. Just a question. Jimmy said we were about to move on. We're good. My bad. Or did the secondary motion get?
Did you get the?
As well. Sorry, we're not the secondary. Yeah. Sorry. Second.
You did a good job. All right. Very good. Let's call the meeting back to order. Okay, okay, very good. After a brief, not so brief recess, we are on to a review of the 2025 financial report. Laurel is up.
Mr. Chair, won't be surprised to know not much has changed in the last few weeks since our last meeting on our financials, so this report will be quite brief today. While I was getting ready for today's meeting, I went back and looked at last year's report for the May meeting, and we are at almost exactly the same point in expenditures and revenue that we are this year. We are also at 90% of our planned revenue, and last year we were at about 79% of our planned expenditures. This year we came in at 90 and 77 respectively. One thing I'll note is that the gap between our revenues coming in and our expenditures has grown a little bit. That's been a pattern the last couple of years. Where we are seeing the biggest discrepancies from what we planned is in our other funds and in our capital expenditures this year. Other funds captures our opioid funds coming in, and that's been really difficult to plan for because we don't know, one, how much we're going to get or when we're going to get it, but we also don't know how many years it's going to apply to. So with some of the settlements, we get several years at once. Some of them are doing annual payments, and we haven't been able to get a good handle on what is coming when. So this is the third year in a row where we've just seen a big discrepancy from what we plan to get in opioid funds. That's represented in the other category in our revenues. So you see the numbers off there. That's what it is. We'll probably continue to see that over the next couple of years. When we get that in, if we're not changing what we plan to spend this year, we put it in restricted funds to spend in future years. So you see that in our high amount of restricted funds that we have also. The good thing about that is when we put it in restricted funds to use in future years, it's gaining interest for us. So it's a benefit to us in that we can use it for opioid related activities, and also that we can gain interest on it while we're planning for future years and what we're going to do with it. No other big changes to note or anything on page 1. Moving on to page 2, we look at our comparison over the past 2 fiscal years. One thing I'll note on this page is that we are continuing to get caught up on our fee revenue, still a little bit behind, but closer than we were for the last couple of meetings. And by the end of the fiscal year, we'll be fully caught up in accounting for our fee revenue appropriately. Still on the revenue side of the page, our fees and contracts are right about at our planned amounts. And then when you move over to the right-hand column for expenditures, you'll see that everything there is underspent. Our personnel, operating, T&B costs, and our capital outlay all underspent, with the capital outlay being the most significant there. And the biggest change to our capital outlay plan for this year was in not doing the bathroom remodel. Talked about it last few months, but continues to show up. So pointed out again, and we only got the single bid in on it and didn't feel it was fiscally responsible to proceed with only one bid. And then on to the final page. We also changed so that all the pages are landscape now.
So is there a game plan, or what's the timeline? Are there other bids coming, or how long, or what is the pause?
Mr. Chair, what we would like to do at our August meeting, once we know how much we have in carryover funds, which we anticipate having carryover funds with that gap in expenditures and revenues, we may ask the board to set aside some funds for as a special project and go out to bid again. What we plan to do when we go out to bid this time is advertise the bid better. Now that the board has approved the purchasing policy, we're required to advertise those bids in a local newspaper. We'd also like to find some other options for where we can advertise to get more vendors in on the bid. And then this time, if we get 2 or more, we'll have a basis for comparison and we're getting a fair offer. So more than likely, that'll be part of our FY26 special projects at the will of the board with your approval and depending on what our carryover funds come in at. So Total cash balances at month end, 13 million. A lot of that is in our reserve of restricted funds. You can see the breakdown of how that's allocated in those different funds. For our special projects for this year, our EH system upgrade, we finished our gap analysis sections or sessions and are now into testing the product that they built for us. Curtis is gathering feedback on that right now from our inspectors, and those will be using the system. We will continue to see that drawing down. We will not spend all of it in this fiscal year. Some of that we will more than likely ask for spending, the ability to spend it into next fiscal year as well. We used all of our employee retention incentive. Our staffing needs continues to be spent down. And then we see the bathroom remodel there in special projects as well. Hall office refresh, we have not started on. I know our facilities manager has spoken with the manager up there. Was out on leave for a brief time. That got pushed back a little bit, but still planning to at least have a start on that before the end of the fiscal year. Subtracting our reserve and restricted funds leaves us a cash balance that's undesignated, unrestricted of just over $4 million.
Very good. Any questions for Laurel on the budget update? All right, our next item on the board is to discuss the district fee policy.
Through Chair. So brief, this will be quick also, but brief recap on where we are with the fee policy. So 2 years ago, the board approved a fee setting policy so that we weren't making individual fee decisions as a board anymore. It used to be that in May, we looked over each fee for FCS and community environmental health and made sure that they were in an acceptable amount to the board. So 2 years ago, we asked the board to approve a policy. And then if we're abiding by that policy, the fees would just be an output of that. So we're not making decisions at the individual fee level anymore. Last year, we made a couple of clarifications to the policy with the board's approval, and then we clarified which years we were going to be reviewing the FCS fees or the conversion factors for FCS fees. We decided to do that in every odd year. That's clause number 4 of the FCS fee setting procedure. This year, when we went back to review the policy, we realized that we had listed in item number 2 under family and clinic services, we had CDH has established the use of the CMS's conversion factor as CDH's conversion factor. We have actually been using Blue Cross of Idaho's conversion factor for the past 2 years. We had an error in the policy. So I'm asking for today as an action item to approve the amended policy, which correctly lists the conversion factor that we have been using, which is Blue Cross of Idaho, not the Centers for Medicare and Medicaid Services, CMS. That's the only change to the policy from what was approved by the board for the past 2 years. If the policy is approved as the action item, the fee outputs that you see for family and clinic services and environmental health services are as stated on the 2 handouts. Sorry, show a question, Mr. Chair.
Yeah, I do. So what's the difference? Is the Blue Cross conversion factor higher
Yes.
by a
Sure.
lot?
Yes, almost twice as much. And it allows us to potentially collect more fee revenue. We still have the sliding scale available for patients and a additional discount on top of that for self-pay patients.
Fee schedules aren't traditionally CMS fee schedules are traditionally provider friendly.
Correct. So the 2 sets of fees that you see for community environmental health, the main thing our fees are based on is the amount of work that it takes to perform the services listed, and then the cost of our staff to do that. So pretty simple way that we calculate that. And then we have added a clause in there that fees won't go down if we're predicting that a fee will go down more than 10%, we bring that back to the board and look at why. that was not the case for any of the fees this year. Most of them either stayed the same or went up by a few dollars. So very few changes there. And the same for the family and clinic services fees. Our procedure for calculating them is different as stated in the policy, but there were very few changes. The biggest dollar amount changes that we saw are on page 2. There are in-office visits for new and established patients. They went up by a range of $14 to about $20. That being you all for any questions.
So those increases, were they due to changes in the relative value units associated with the CPT?
Either the RVUs or the conversion factor, or one or the other.
It seems like the most, excuse me, Mr. Chair, the most complaints I get from the public, and I don't know if Chris will compare, is sewage and land applications, especially sewage. So it's, yeah,
Early.
yeah. I get the comments like CDC has become harshly restrictive and they want you to put in very expensive systems when a lesser system that we used is totally as adequate. So I don't know. That's kind of what I get. And that's from plumbers.
Mr. Chair. I do not know any of the requirements on that. As far as I know, the requirements that our inspectors inspect for have not changed. And the costs for that are based on their salaries and the operational costs just to perform the inspection. It doesn't include our indirect costs or other costs. So even when we say we're calculating the cost of the time to do the work, it doesn't include all of the costs that it takes. County or the district fees still support that program as well.
Mr. Chair, but again, does that go to like the individual complaining that the requirement is too rigorous or overkill?
Yes, I know, first, I've been on this board long enough to have been through several public health sewage guys. And now they're saying that we have one in particular that wants you to go to a much more expensive, high-tech system when a lesser one would be as adequate.
And is that something we can change or is
I don't know that,
is it in state
well,
statute or is
the
it?
FEMA head got fired yesterday, so
Mr. Chair,
I
yes.
don't know.
Yeah, I will just say that the statutes that we follow and are using in making those determinations are governed by the Department of Environmental Quality, and they in turn contract with us to do this work. And so we are enforcing state statutes that are governed and regulated by the Department of Environmental Quality.
Thank you.
They're not individual rules or restrictions that CDH has created or implemented on their own. They're statewide statutes.
So we'll see, maybe the administration will do something. I don't know. And I must admit, I'm in an area that is more rural than, downtown.
Oh,
Mr. Chair, are these part of what Rod was talking about? The environmental needs that are set, if we don't recover what we recover.
Mr. Chair,
yes.
So the pool program, which as you all know, it's going away, is set in code at a fee less than what it costs us to do that service. That fee's been in place for more than 20 years. And then the food license fees are the other fee set in Idaho code. It doesn't allow us to recover the cost where this board to set that fee. So that's where we're subsidizing it basically with county funds to the tune of about $800,000. So it's significant. But we do over 3,000 food establishment inspections per year, annual plus complaints, plus follow-ups. So it's actually over 4,000. We only charge for the annual. Essentially that comes out of this license fee, but then the other costs are part of the cost of running the program too. So it's, yeah.
Do we have the math on that? So roughly how much do we lose per inspection?
Oh,
On the restaurant.
it's more than 50% is being paid for by county tax dollars. That's correct. Mr. Chair?
Yes.
So this is a topic that has come up just about every single year. Betty Ann noted, she's been on board for a while, that it's something that boards of health throughout the state discuss. It'll be discussed again this October at the annual boards of health meeting, which is well, it's actually going to be held here, but District 3 is the host. So I would encourage, you all, if you're attending that meeting, or we will have discussions leading up to it, like in August, as far as what you want to do. The thing that hasn't exactly happened is strong support from the Idaho Association of Counties, and they have I think it's called a legislative committee that sets the priorities. And this has been brought before them, but it hasn't made it to the priority level where Idaho Association of Counties is actively lobbied to make this change. And the change, by the way, that the boards want is to take the fee out of Idaho code. And that then defers it to you all to set the fee like you do for everything else.
So just to clarify, how much does it cost us to do it per inspection? Or is it vary depending on some type of inspection?
So, Chair, I don't have the exact figures as per inspection, but for example, in our fiscal year 26 budget that was recently approved this morning, we are projecting $1.5 billion in expenditures to carry out our food inspection activities, with total revenues projected to be approximately $686,000, leaving approximately $834,000 in county funds needed to help us cover the gap between what the fees cover and what is necessary to cover the operations personnel and everything necessary to conduct the work.
So, Mr. Chair, sorry, I'm just gonna say, looking at the cost, the fee for a regular food inspection being at $200, knowing that covers just under half, yeah, close to that range. We'd have to take out indirect costs and stuff, so probably in that 350 to 400 range would cover the movement.
Any other questions? So then this is an action item, so we need to approve it with the amended clause change.
I would make a motion that we approve the new Central District Health and Fee policy with the change to number 2.
Second motion.
Okay. Motion and second. Any discussion on that? All in favor, say aye.
Aye.
Any opposed? Proof and sign, there we go. All right. Last item on the board on the agenda is positions. Positions. How do you want to conversation? Do we want to go right into nominations?
Mr. Chair. I totally up to anybody else to nominate, but I think the flow is working well as is. I don't know if Greg likes sitting in that chair or not, but he's got a lot of political experience and Dr. Furch should play as chair and vice chair. I'm good with that. Anybody else's suggestions? I would volunteer, but I know I'm gone too much.
So
I've been voluntold a lot of times in my life, but.
I was going to pull them not there.
Right, exactly. Yes.
Right.
So we could, I guess, knock it out in one fell swoop. If that was a motion.
I'm
Can we
open
do
to
that?
discussion first if anybody else has, like, wants to volunteer.
Right. I was gonna say, I think you said Betty Ann, right? Also?
I'm looking at the guy that has the legislative experience for that seat.
For executive council.
Yes.
You're tired of the executive council?
You know how many years I've done executive council?
Heard it's been a while.
And you know, he sat in there. He sat in there.
Yeah,
If you did that, would you do the chair?
If he would volunteer to do that, I would do the chair.
I've kind of been there, done that part of it. I probably,
That's why experience counts.
yeah, I'm good from the outside on that one if. It's the board's decision, but
Generally, what does that one involve?
Okay,
For those of you that have done it.
okay, you should be very involved in the state meeting that's coming up in October. And starting, there are several meetings during the year for the executive council. And the directors are also involved in those. And then in January, we start with usually scheduled weekly teleconferences regarding legislation. So, and that will go through usually the end of March. So yes, that's where the inner workings of that would be valuable. But
I'm intensive.
I'm
Time intensive.
The meetings starting in January can be very brief. If they're telephone meetings, and sometimes they tend to be quite lengthy discussions, but very important. And IAC is on all of those meetings with us. Russ, do you have anything else to add to that position?
Yeah, if I could.
all right. Train. Pardon me.
No, just saying that one of the shortcomings of that group, not the individuals, is the difficulty in making decisions. And that's what I think you would agree is, I think at the October association meeting, there needs to be very clear, more clear direction and expectations for what they do, because Betty Ann attended every meeting, but a couple of the meetings, there weren't even enough executive council members to have a quorum. I think the most we had was 4 out of the 7 present in these weekly meetings. So part of it is, I think when you're in that role, I shouldn't have looked. Whoever would be in that role would need to participate and be willing to speak up and be willing to make decisions. Because the point is, if you reelect Betty Ann or choose somebody else, it's a critically important role. Like when the food establishment or the pool decision was coming up, there was conversation about it, but there was no motion, there was no action. And then where that leaves us as directors, because we're more than happy to do the work. Do the work as in go meeting with legislators and saying, this isn't okay. This is something we need to continue to do, which our board talked about. But I think it's better if it comes from Board of Health members and from the Idaho Association of Counties as our lobbyist organization. And it is critically important because there are bills coming forward now, one draft, to eliminate the public health districts.
Yes.
So this is not like stuff that's sort of irritating. It's incredibly irritating to me, as you might imagine, but I'm not talking little nuisance things. These are big decisions coming up. And there's probably going to be more of that coming forward in the 2026 legislature. So whoever chooses that role, if you're willing to, you know, to have a strong voice, that's what we need. And it's hard when don't even have a quorum to make decisions. So I hope we can get some clarity on that in October by the full body and give direction to those executive council members, because no boards of health want to meet weekly from January through March, but you essentially delegate that authority to whoever you elect to make those decisions on your behalf during the legislative session. They should be in contact with you, you know, when things are coming up, or we can hold special meetings or whatever we might need to do, but it's not been working like I think it should.
No, and it needs to be somebody who will keep the conversation going. Absolutely, because sometimes an issue comes up and IAC is not very proactive for us. And we've talked about that at great length before. But it needs to be somebody that will keep the conversation going. And I actually think of our positions, that might be the most important one for our group.
Well, there you have it. My preference is to remain a bit more flexible outside the legislative process. I can exercise influence when need be, I imagine. But if truth be told, if the board would have me to state put, it would save modifying the website. See, looking out for the taxpayers. But that's up to, that's up to you.
Would you be willing, though, to use your experience down there and then knowing the committees and the people you know?
Yeah.
Do that.
Well, I have no problem with that. I mean, I found my way down there. I pick and choose a little bit. I don't want to, you know, overstay my welcome, but I was down there a couple, 3 times on things that meant something to me personally, not having, you know, specific guidance or direction from the board, for instance, on the forcing or requiring elected officials to be members. That was on my own to go down there and speak against that. I think that, you know, you bring a lot to the table despite not being an elected official. And I didn't want to see personally, again, I wasn't representing the board, but personally, from public policy, I spoke against that. So the point is, I have things that come up that I'm interested in and ultimately passionate about, but I would be glad to help out and do things, but
I think whoever is in this position needs to be very pro public health districts, because there's this year, District 3 had a chair that is kind of spearheading doing away with us. Would you agree, Russ?
Yeah, I'm concerned about some of
Yeah.
the conversation took place.
doing away with the districts or
Yes.
doing away
Yeah.
with the association of the districts.
The districts,
And the association.
yes, and the association. So you have to be very pro public health district if you're going to sit in that chair. And I think it's immensely, I can't even imagine. Okay, each district, if we dissolve as public health districts. Okay, Caitlin, look at the water table she has up there in the spring. Everything is flooded. Every drain field's flooded. And they're gonna decide who's gonna be their inspector. And another county has, oh yeah, we'll have somebody else. The fragmentation and the cohesiveness of that issue, which is huge from a public health standpoint, I just don't see it holding together.
Sounds like you're talking yourself into staying involved in it. You're so familiar with what it requires.
We've only done it for what? 4 years maybe, you guys? But no, I think
She
that.
knows where all the septic tanks are buried up there.
It really, because there is active negotiations going on to get rid of us.
Well,
Therefore, I would nominate you for executive council and trustee.
I don't know, I would almost respectfully decline that.
Really?
I appreciate the sentiment, but,
I would do it. I already know I'm gone. Already booked for a bunch through next May, so my availability, being a willingness, yeah, but availability, unless it were something we would like split between 3 of us. You do this one, you do this one, you do this one, and, you know, then like a council of the minds together. I don't know if you can do that by rule, but, you know, that might be, you know, a little more flexible.
It's a tough one. I wouldn't mind doing it, but I don't want to say I'm committing too much time. Not be able to.
I just need the flexibility with my office and, you know, I'm off
I will
on
say,
Fridays.
I will say that the meetings in large part are pretty much, you know, teleconferences now, so you don't have to travel. IAB is an important thing to me, which will be here.
Well, I guess let's see how it unfolds. We've got to start somewhere on this nomination process, and so.
Volunteer as proxy to go when whoever the executive council member can't go, but have to just coordinate schedules.
How do our bylaws,
That's what we're reading, great.
do they address that?
Sorry, Mr. Chair. So in that proxy, if the trustee is not able to, would fall to longest serving board member, so we couldn't necessarily do, so we'll have to.
Yeah, I'm not, while you're looking at it is, I mean, that's for our board meetings, the chair, and then the vice chair, and then the trustee / executive council member would be third in line to basically run the meetings, but I'm not thinking there's anything that would prohibit. Okay, if you see something different.
I'm just
I don't think there's anything that would prohibit to have a vice trustee or vice executive council member who could attend the meetings so I keep using the term trustee and executive council member. Thanks so much, Dr. Young. You're going to be nominated for all.
Cheers, Jane.
Let me know. Thank you. Have a good weekend. So historically, the trustee, which is an Idaho code, that position is the only position on the board that's in Idaho code. So that trustee is responsible for determining state appropriations and how that single state appropriations and how that gets divided among the 7 health districts. For the most part, that role's kind of gone, although there's still some funding like home visiting funding and the Millennium funds that the trustee has been part of that conversation with the 6 others to determine how that money is distributed. The executive council came about probably 6 or 7 years ago, so that there wasn't blending between an Idaho code position and then a lot of the conversations that we take place around policy. So generally it's the same person. That's how we've written it in. You all have chosen to include it in your bylaws. the chair and the vice chair is just a bylaw decision that you all make. So that term trustee, executive council members, I think we use it interchangeably because it's usually the same person, but different functions. Make sense?
Well, then there may be an advantage to having a different set of eyes, on the issue. But I think one of the main things is just be very verbally active, because a lot of people aren't, and things fall through the cracks.
So I'm not certain where that left that, but we need to probably take.
And we vote on the chair and the vice chair for executive.
Yeah, and then the last guinea pig. So we should probably then just start individually. The hope of doing a slate seems to have escaped us unless you're willing. So let's take nominations for the chair.
The chair, I nominate the current chair to continue to be the chair. Dr. Furch.
Let's second.
So if you'll all continue to have me, I'd be happy to do that. Now I want to continue to look at things like we looked at the WIC program and some of those things I'd like to be involved in and look at some of the nutrition policies. And probably not a surprise that I'm a proponent of nutritional sufficiency, and maybe there's a way that we can bring that a little more completely to our home visits and things like that. So I'd be glad to continue to do it if you'll all have me. So,
Chair, I do have to input that I like looking at the WIC and the things we did there, and I know we looked at that and thought, what in the world's going on with that?
With the WIC thing?
Yeah,
Yes.
with the food choices. Yes, exactly what they didn't recommend and recommend. But I do think that, stuff that goes on the agenda, specifically this time was the COVID. I had no idea that was going to come back. So I would like a discussion amongst the board before that it comes back with all due respect. And then, and in speaking about that, I don't know if we can address that now as far as getting the vials tested. I would like to see that on a future agenda, if the board so chooses to have that, even though we've tabled it. So anyway, I guess that is something that I would request of the chair.
Certainly, I'm open to critique. I want that to be so. If that's a guidance or ask from those of you.
I think it's very helpful to have a board discussion in the information item discussion before it would ever become an action item.
I agree, because I felt it was sorry, Mr. Chair, it was really rushed. We all knew we were way behind schedule. And I think some of us weren't able to say everything that we wanted to be able to say. I would like it as an information item before an action item.
Good. Well, thank you for the critique.
Not necessarily a critique
Or suggestion, or, maybe that's it's a good policy.
We've kind of
good
made it
policy.
close that way before.
Okay.
So we're informed before we ever come to an action item.
So I guess, is that the end of the discussion? So all in favor of keeping me around?
Aye.
Thank you. All right, so next up is vice chair. Do we have any thoughts on that before we get to last guinea pig?
Is Jane our current vice chair?
That's right.
Well, he is. Oh,
Everybody wants
he's doing a good job. He's doing a good job. I nominate Clay to remain in that position.
Like, good.
That's fine. As long as Greg shows up.
I'm gonna miss the next meeting just to thank you sit here again. All right, any conversation about Commissioner Tucker remaining as vice chair?
And my only critique would be, make sure I'm included in the blue shirt club that day.
Yeah.
Get the memo.
All right,
Teasing just.
so all in favor of Commissioner Tucker remaining as Central District Health Vice Chair, please say aye.
Aye.
Any opposed? Anyone want to say no? Or someone does. So the last thing on the agenda is this trustee nominations.
Mr. Chair, is there any problem having multiple vice or co-council members, trustees, whatever position you want to call them? Is it possible to have two of them? I didn't.
Mr. Chair. So the current bylaws don't really say one, yeah, right, one way or another. So if you wanted to, I mean,
That is an option.
you all could do whatever you want, and you can change the bylaws to allow that to happen. These are your bylaws, they're not set in code.
Basically a trustee and a co-trustee.
So is there a lot of, I mean, are there votes that are taken on policy or position at a lot of the meetings?
Yes,
Okay.
it's informational, but yes, we do.
Okay, so then the person that happens to be at that respective meeting or the representative would be charged with that vote and taking that position.
Charge that vote. Russ, which district is next in line after District 3? Or
Association rotation.
association rotation?
I don't know, but I will find out. I can't remember because it's not consecutive. It's,
That's right, it's not consecutive.
what's that?
It's not numerical.
No.
That would make far too much sense.
Yeah.
Yeah, right.
Good, keep it calm.
And on that rotation for a trustee, whichever district is next, say if it's District 5, that person will chair the committee for that year.
So that's what was up.
Like two or 3 years. So we did, was it us? Coeur d'Alene, Idaho Falls, District 3. I think we were before Coeur d'Alene, I think. So Coeur d'Alene. We're coming up in about 2 or 3 years. Check. But not next year.
Well, my thoughts are have Dr. Ryan Cole as the executive council member and Betty Ann Hamilton as the co-executive council member, just in case he can't show up. She already knows what's going on.
There's first.
Now, just disclaimer, my term is up in May of next year. So, you
June
know,
30th to be exact, but
What?
May will be the last meeting. June 3rd, you have to, June 30th.
so, yeah, and elections are only every 2 years. So, yeah. And it's an appointed position. So.
If
Are
I
you-
did appointed, I was gonna say as a county commissioner from our county. but-
Yeah, are you gonna give her the boot or what?
No, that's what her intention is.
I'd be happy to do that if.
We can.
We can just look at calendars.
I will second that motion.
Co-trustees.
The initial motion.
Okay.
Commissioner Tucker. Great.
And then
I didn't.
Commissioner Caldwell, second. Okay. So that's, motion before us, any discussion? All in favor, say aye.
I,
Any opposed? Right, that motion passes. So do we need to volunteer somebody for something else?
Yes.
No, I just.
Sure. Yeah. Good work. All right, so I just want to publicly thank Corey and Dustin and, whomever I'm unaware of behind the scenes for making this thing happen this morning. A little bit of a tech hiccup, but they overcame, and I think it was a great, good job, good job. Bottom line, and then Russ, I know he was fielding and doing a lot of behind the scenes stuff with that too. So again, thanks for doing that. Russ.
Yeah, just real quick, you all don't meet again until August. It doesn't mean you can't. If something came up that you wanted to hold a meeting, all the open meeting laws that Corey's obviously very familiar with, we would have to, post a meeting and what have you. In the past, it was June was the Idaho Association of Local Boards of Health meeting, but that has been moved to October starting last year, and it sounds like that's going to continue this year. So we don't meet again until August. So if things come up, if you want to meet, let me know, or let our Dr. Birch know as our chair. And then the last thing I want to say is I want to express my sincere appreciation for all of you for supporting our budget, which was the start point. Enjoyed going out and meeting with the commissioners, and thanks to those of you who were able to attend. If you're not a commissioner, that was great. Have you be present, and I know our staff will really appreciate having the salary increases built in this year. I know it was it took a lot of money to invest into our team to both express our appreciation, and of course on the retention side, we hope it'll make a difference there too. So good outcome. I appreciate, of course, the budget committee, 3 of you, and I'll make sure Commissioner Beck knows as well. So thanks for your ongoing support.
Anything else?
Yes. I came on this board in 2003, and you know, have the record for the longest meeting.
I now
Congratulations.
From 10 to 10:15. Okay, with that, I'm just gonna let you languish here for a while.
No, we did have a late start, so you should.
We're adjourned.
You, everyone.
Thank you.
There's table boxes if you got someone at home that wants to.
Yes.